I'm still muted. Yeah, no, no. Still got the life is not a journey. But the grass is better. I'm assuming I can start. Right, I think you started.
Professor, you can now start.
Okay, all right. Thank you very much and welcome everyone to the session, skill building session on strategies and considerations for implementing digital health interventions in low resource settings. So kia ora koutou from New Zealand. It is 5 p.m. in Auckland with my colleagues here, Robin Whitaker and Rosie Dobson. And over the next 2 to 3 hours, we're mindful of the fact that 3 hours on a Zoom call is a very long time. So what we're going to try and do this afternoon or this evening here, your morning, is present some of the work that we've been doing on using case studies as a way of presenting some of the lessons we've learned, some insights we've gathered over the years we've been working in digital health. And ideally, I guess, provide some pretty practical guides, some tips and strategies for thinking about and then delivering digital health interventions in environments where there are low resources. So firstly, I'd like to acknowledge my colleagues, as you will meet in a moment, but also the people who we work with. Really, it's way more than just Robin, Rosie and I. It's usually a considerable team of people, both obviously in the countries we're working with, our funders, the organisations who think what we're doing is a good idea and are willing to back us, our colleagues who really spend a lot of time doing a lot of essentially the research work that goes on behind digital health. Data entry and so forth, but also the colleagues we work with predominantly in country and in Auckland University here. So so first of all, I'd just like to acknowledge and introduce my colleague, Dr. Robin Whitaker, Professor Robin Whitaker, who actually got me involved in global health and digital health right at the very beginning. So I'll pass you over to Robin just to introduce yourself.
Right. Hi, everybody. So I'm a public health physician. I'm Associate Professor at the University of Auckland and the National Institute for Health Innovation, where we've been developing in-health behaviour change and self-management support programs now for about 15 years. I also work in a health service where I'm the clinical director of innovation, so also working on trying to implement a lot of these digital innovations in the real world of the health services.
Thanks, Robin. Okay, and I'll swing you around to Rosie. Just so you can see what you're looking at.
Hi, I'm Rosie Dobson. I'm a psychologist who is also based at the National Institute for Health Innovation at the University of Auckland, working alongside Robin and Jude now for a number of years, both in the development and design of mHealth tools, but also around the evaluation of these and the rollout or the implementation of those into the health services. So welcome along.
Okay, thanks, Rosie. And myself, I also work in Auckland University. I've been teaching in global health for about 10 years now, maybe longer, and really interested in, I started off being interested in how young people in particular use popular media, how they make sense of it, how it influences some of their perceptions and behaviours, health-related behaviours. So, as I mentioned, when Robin invited me to do some work with her around trialling the use of a mobile SMS text message program to support people to quit in Samoa, this seemed like, to me at the time, a logical transition. Of course, it's very different, and I've learned a huge amount over the last number of years working with Robin and Rosie. So my background actually is in public health. I did my PhD in health psychology. Okay, so this is the plan for this session. What we want to do is talk about some of the case studies, I guess. So we've got some examples we think will be really interesting and relevant to the purpose of this session. In particular, I want to talk about the work that we've been doing with Samoa, the Ministry of Health in Samoa, and with the Ministry of Health in the Cook Islands, and that's around trying to support people to quit tobacco use. So I'll talk a bit about that to start with. Rosie will talk about Text Match, which is a program that she and others have been developing, helping women, pregnant women, families for a healthy lifestyle, particularly nutrition, and also SMS-4BG, which is a program designed to help people manage blood glucose, people with diabetes. And though we thought with those three case studies, it was a really good basis for then addressing some of the key skills we wanted to, I guess, develop or work with you to develop over the session. So we're going to then address the 4 key points, that the skills that we wanted to work on, and we're going to draw upon and kind of dig a bit deeper into these case studies to really sort of, I guess, use them and to illustrate the points we wanted to cover there. In terms of we want to be able to support us, you as a group to think about some of the indicators, what would suggest that your country or the setting or this community would be a good place, an environment for a digital health intervention to be useful in. So it's not right for every situation or every context, even though it seems like a great innovative solution. Sometimes there's some things that indicate that it might not be so. We also want to be able to explore some of those, what we call the requisite key capabilities and capacity needed to really not just develop and adapt and implement this innovation, this digital health intervention, but to actually make sure it sticks around if it shows an impact. And then we're going to look at how to develop a basic work plan for an SMS-based health intervention. So how do you sort of plan the work that's required to implement and evaluate an initiative? So thinking beyond, this might be a great idea, this is going to be a solution to a problem, but to actually figure out, actually, do we have the skills, the resources, and how much time do we need, and what is the kind of core requirements essentially to plan the work ahead. And then really importantly, we want to consider the elements necessary to evaluate whether this intervention is equitable, is it fair, is it accessible for all people, and particularly the most vulnerable, whether it's effective, is it doing what it was designed to do, and is it appropriate for that context. And just to elaborate a little bit further on that, Rosie will discuss a checklist, which is really helpful in helping organise the planning and just checking in that you've got those key elements already built in right from the outset. And then we're going to finish, and again, we may well finish within, just over 2 hours, if that's okay. We'll see how we go. With some of the key lessons that we learned, as a team and with other colleagues. So we've got sort of 4 key points we're going to go through that we think are quite helpful, that we've figured out, often through mistakes made or things we could have done differently. So that's the plan for the session. Now, if you've got questions, by all means, write them down, but please use the Q&A on the platform. I think that apparently is the better way to go. So what we're going to do is address those probably more at the end. So we're going to try and pick them up, the ones that are really pressing. We'll keep an eye on them because we're all in the same room, makes it a little bit easier here, but also then address them at the end. Okay, so off we go. So I'm going to start by just putting the work that we've been doing in the Cook Islands and Samoa in context. And I think context is incredibly important when we're thinking about any type of intervention, digital or otherwise. The Pacific Islands region is really distinctive for many reasons. I mean, it's a unique geographical region, hundreds of islands and atolls widely dispersed across this vast Pacific Ocean. So there is this enormous seascape, but actually what's interesting as well is while there's a huge sort of breadth of sea, there is a strong connection between the 22 countries and territories that make up the Pacific Island region. And the distinctiveness about the region is not just the fact that they are very well, that they think regionally, they cooperate regionally, they draw upon regional resources and kinship and similarities in terms of Pacific values, but also, of course, the important distinctiveness between each of the countries, linguistically, culturally, and many other ways, politically, economically. So the region is really, really distinctive. It's also a very close, has very close relationships, not just with each other in the countries, but also with New Zealand and Australia, particularly. So New Zealand has strong bilateral and multilateral relationships across the Pacific Island region. Probably New Zealand most strongly, and based on historical trading relationships, has strong relationships with countries in the Polynesia region. So that is countries like Tonga, Samoa, the Cook Islands, Niue, Tokelau, but also the countries over towards Australia, the countries of Melanesia. Also, we have strong relationships with, and there's a lot of bilateral and multilateral economic trading and other partnerships. The northern part of the region is Micronesia, and that's where a lot of the US affiliated islands are. And again, we work where we can and with the countries in the North Pacific. So the region is a fascinating part of the world. New Zealand, of course, as I mentioned, has got a strong relationships. And Auckland in particular, where we're based, is actually the biggest Polynesian city in the world. So there's really a lot of flow between the countries, particularly countries in Polynesia and New Zealand. It's really interesting in terms of how radically different New Zealand and the Pacific Islands region is. In terms of flying north from Auckland, takes you about 3 hours to reach Samoa. And in Samoa has now moved up in the World Bank, ranking to an upper middle income country fairly recently. But it's extremely distinct from New Zealand, which is a high income country with high, access to resources, including information and communication technologies. We have a very different profile in terms of a burden of disease. In some ways, although I think what we're seeing now, of course, globally is there's emerging, of course, with the epidemiological transition to much higher rates of NCDs in New Zealand as we're seeing across the Pacific. We don't have in New Zealand, like the Pacific is dealing with, there's such a high burden of vector-borne diseases. So it's very unusual, but it's not completely rare to have people coming in from the islands with, migrating or visiting New Zealand with dengue, chikungunya, but particularly the Pacific Islands region is really vulnerable to climate change. And these changes in habitat and ecosystems, of course, underpins this increase in vector-borne disease. A lot of the health systems in the Pacific region are under-resourced. This is characteristic of really a lot of course, low-resource environments. They are under-resourced. A very low proportion of the GDP is attributed to health. And with that, you get a high reliance on other countries, in particular Australia and New Zealand, in terms of resourcing. So again, there is a lot of, I guess, the New Zealand Aid Program provides some support, but not just through that program. Other mechanisms of bilateral and multilateral agreements and funding and support is existing in the Pacific region. So what that does is, of course, over time, that really it weakens health systems. It's not a sustainable mechanism. It's really important that it is there for stability and to ensure, access to universal health coverage, etc. But over time, this has weakened health systems. But importantly, in relation to this particular session is the changes in the region to information and communication technologies. So the region has one of the lowest rates of access to the internet and mobile subscribership. This is changing quite radically. Of course, over the last 10 years, it's really changed as we've got greater competition and some markets were deregulated. So you've got more than one telecommunications provider. So that really is important in terms of increasing access and reducing costs. But we're still working on developing submarine cabling to ensure reliable, consistent connectivity to some of the islands. So that's really been one of the reasons, perhaps, that explains why there has been a lower uptake of digital health as a sort of a mechanism supporting health system strengthening in the region. But this is changing. So as I mentioned, we've got some gaps. We also know that this is changing. So we are increasing number of people owning phones, increasing a number of people now have smartphones and as opposed to basic mobile phones. We've got huge diversity in subscriber penetration rate from, as I said, 16% of the Marshall Islands, which is in the Northern Pacific region, to 80% of New Caledonia, which is a French territory. So huge diversity, and in between, probably most hover around 50 to 65%. And that's shifting. So when we try to find out what's happening in the region in terms of mobile data and subscribership, there's not always great information. It's really not always up to date or accurate. But our sense is that the Pacific relies upon and is increasingly going to rely upon ICT to strengthen health systems, to deliver equitable, accessible healthcare, and it's going to become increasingly important. And certainly the recent and current situation with COVID-19 has just really brought that to the fore. We really understand the importance of connecting with the region in terms of surveillance and data. So just for the next few minutes, I'm just going to talk about an initiative that we developed with Samoa Ministry of Health, and it was designed to support the Ministry of Health to achieve one of its stated targets of reducing tobacco use in countries. So Samoa is a country in the North, not in the North Pacific, in the Polynesia region. It has a relatively high tobacco prevalence rate across male and female of about 35% the time we conducted this work. There didn't seem to be any significant changes. There weren't many other initiatives in place in terms of cessation programs. There was a mass media campaign, but access to nicotine replacement therapy and other forms of counselling, etc., was not available. So this pilot really was designed to see, can we adapt a text message program that was designed to work, designed in New Zealand and demonstrated good effectiveness. So doubled quit rates for those smokers who wanted to quit and signed up to receive this sequential series of text messages to support them through that change. So the idea was, would this work in Samoa? Could we take a tool that worked well in New Zealand? Now there are some, again, I mentioned the similarities in some respects between New Zealand in terms of population. For Samoa, again, contextually really different. So we want to know, was it feasible to deliver this text message program? Could we adapt it, and what was involved in adapting this program? How far did we need to adapt it, and was it likely to be effective? So could we expect the same level of impact in terms of quit rates as we did in New Zealand? So this initiative was launched probably in 2015. I'm just going to show you this diagram really briefly. It's not hugely important, but in some ways it demonstrates a bit of what we're going to pick up on later. So this was funded by the Ministry of Foreign Affairs and Trade in New Zealand and the Health Research Council of New Zealand. But it was so the funding has come from New Zealand to support this initiative in the Kukai in Samoa. But the willingness or the enthusiasm for this program was also very strong from the Ministry of Health of Samoa. They looked around and said, look, people use their phones all the time. It's a big part of life here. Yes, we've got a problem with smoking. Let's see if this would work. So the kind of rationale made good sense. And it was part of, this is what we won't go into this in too much detail unless it comes up later. It was part of a broader agreement between the United States, New Zealand, and the Pacific to collaborate to improve health service delivery, to build these partnerships. So that was the long-term outcome. So we kind of trial this pilot and see what it leads to in terms of longer-term collaboration for research. But the shorter-term outcomes were really around, can we understand this process required to adapt an MC cessation initiative in other Pacific settings? Will it strengthen capacity and local leadership for MC cessation? So by developing this initiative, are we going to help build capacity that would stick around, that will be resident in the Ministry of Health and be used to support other programs in the future? And importantly, we also wanted to know whether, if we ran a mass media campaign alongside the MC cessation program, so the text message program, will we also increase public awareness of addiction, cessation in Samoa? Because it's really hard to change behaviour in a small proportion of the population if the rest of the population isn't coming on board with you and there's no underground of support there. So that was the kind of broader program. The timeline gives you an idea of how long it took to get things up and running. Now, these were very early conversations here in the early days, a lot of consultation and discussion and around whether this was the right thing to do and ethics approval. We took some time, of course, it took almost a year to adapt the text messages because we had to start off with a bank of messages, a large number of messages that were designed for New Zealand. So they had references to this environment and they were all in English. So we went through this process, and this slide really just demonstrates really simply the kind of, and it's a slightly pared back version of the many, many things that went along the process. And actually this has come from, this particular timeline came from a process evaluation. So no, we were also very interested in not just seeing whether the outcome was people could quit, but also what was involved along the way. So very briefly, in terms of what we delivered, we had to do that initial engagement with the Ministry of Health and other stakeholders in country, that's including the Cancer Society and the Ministry of Health and the World Health Organization and smokers. We did an exploratory study asking whether people like using their phones or receiving health quit messages on their phones. We developed the intervention itself, which was the messages to support people to quit. And then we followed people up over a number of weeks. I believe it was 12 weeks. Yep. So the process of adaptation and intervention was developing the intervention, as I mentioned, was quite Took some time, and we really fastidiously did this. So this wasn't just take the messages from New Zealand, translate them, make them look Samoan and deliver them. It was very carefully done to ensure that linguistically it was very well adapted, so to speak, and it was acceptable to smokers, it was acceptable to the Ministry of Health who would be delivering it, and we would get good, it had good credibility. So each of these stages you see in this flow chart here is each a really important phase in the overall program. In the end, the whole kind of point of it was to recruit 100 smokers, which we did remarkably quickly, despite the the long build up to it. So we recruited 100 smokers. We also ran the mass media campaign, which we won't talk about in the session, but was really important. We followed people up for 3 months. And then we also did a cost effectiveness evaluation to see what it would look like if you were to deliver this program without any sponsorship or support. And the message program, again, was a process of sending people messages leading up to their quit day and throughout their process of quitting, 2 messages a day, etc. And then a series of messages that supported people through that process, that phase where people are most likely to relapse. So this wasn't radically changed. So the actual design of the text message program was pretty similar, to the existing original program that colleagues at Auckland University first developed. So that was really important. The integrity of the program was very consistent. It was evidence-based, it was based on behaviour change theory. It was the language, the representation of relevant cultural behaviours that were changed, and as I mentioned, really, really carefully changed to increase acceptability. So we recruited people and we got a reasonable mix of participants in terms of male and female. Most were in Apia, which is the main centre in Samoa. We got a proportion, 21% were from the villages outside of Apia. Interestingly, despite the very, very careful process of a linguistic translation and back translation and then final checking and approval at the end of the ministry, 51% still wanted the messages in English. So it's really important we had the both, a Samoan and English version. The Samoan languages, the words are very long, so that was quite, again, accounted for some of the time it took to really adapt those messages to make sure that they weren't changed but were consistent. So what we found was people really liked it. 93 would recommend it to others. 85 felt it was effective support for Samoa. So it made sense to them as Samoans who smoke and want to quit. So these are really important. And sometimes we're almost a bit sort of fly over these qualitative results, or they feel like they aren't as important as did people quit or not. But actually acceptability, as we know with any of these programs, matters a lot. If people don't like the messages, they find them disrespectful, they're not encouraging, they'll text back, stop. People typically don't want to be bombarded with messages that are not welcoming and encouraging. But importantly is that we've got a 40% reported a 7-day abstinence rate. So that compared favourably with the original program and then the US adaptation of this program. So we were really happy with that. That was a very good result, given that there is not a lot of kind of, I guess collateral, a lot of additional tobacco sort of control work going on in countries. So you don't have the constant mass media messaging, you don't have brief intervention from health providers. Tobacco is relatively cheap, very cheap and so forth. So I thought this was really encouraging and gave us a good indicator that this could, again, not be the only thing. You wouldn't recommend that this is the only thing the government invests in to support people to quit, but it certainly appeared that it would be a great adjunct to investment in other areas of tobacco control in the country. Oops, sorry. So I'm just going to briefly mention the Cook Islands MC station, because essentially what we did with this was look at what we did with Samoa and the Cook Island Ministry of Health. Our colleagues in the Ministry of Health came to us and said, could we try this it looked like it worked well for Samoa. Cook Islands has a high rate of tobacco use, and we could, it could be of benefit to smokers in the Cook Islands who want to quit. The difference with this program was that we abbreviated the process, whereas we took a number of years almost to get to the pilot phase in Samoa. The Cook Islands program was all done, I think, within a year, from concept to delivery of results. So that was really important, that it proved to us that actually perhaps the, one, we knew what we were doing a lot more, we knew how to kind of what to focus on, which we can pick up on later, and that, getting the translations right, the adaptation of the messages was really right. But we also found that people liked the program in the Cook Islands, that they found it encouraging and supportive. We had a lower success rate here, which we will talk about a bit later, and the reasons why that wasn't as successful in terms of quit rates and in terms of its potential for sustainability. And we will pick up on those. It really addresses some of our questions later.
Just before you move on, Jude,
Yeah.
we've just got one question
Yes.
that's come through online about the availability of electricity and internet services in some of the very small Pacific Island nations. And did that affect what we did there?
I think it's a really important question, because for a lot of countries, this is at the moment still not entirely feasible. Although I have to say, internet is really costly in the Cook Islands, for example, but SMS messages. So that's one of the benefits of using basic text messaging, one-way text messaging. So it doesn't cost anyone to receive the messages. The cost up front, or the cost of delivering the messages, was picked up by the support we got for this program from the WHO, who supported the Cook Island initiative. And quite often at the moment, while there's not too many of these programs going on in the Pacific Island region, the telcos are really supportive of providing the messaging with some sponsorship. So yeah, so that's a good question. Some countries it would not be feasible to use. Certainly we wouldn't, I wouldn't like to try an app-based initiative, but we're really seeing a lot of potential for simple text message programs, and increasingly potential for social media programs.
Can I just add a comment to that? You don't have to turn the camera, but one of the things that we do consider when people might have sporadic access to the technology, so in some countries it may be that when they get to their workplace that they have power or telecommunication access, is that it's really important that the timing of whatever you're delivering is not an essential component. So if you can't control when they're going to have access to the program, you can't therefore time or have elements of the program delivered at certain times. But that doesn't mean to say you can't intervene at all. It's just something that you need to consider in your design.
Okay, it's a really good point. So not having programs that are time dependent, because they might not get those messages for several hours later.
Yeah, or even days. So we have worked in communities whereby they might go into town for work, and so they'll get all of their content come through at a certain whenever they drive into town, or they move into that area. Or it might be that they only get it once a week when if it's something that requires data. It might be when they go visit the church or the marae in New Zealand, where they have access to the internet. And that's okay. It's just when you first do your scoping of the population and working out what is going to best serve the population, that's one of the things you're going to take into consideration. And A, what modality or technology you use, but B, how you design the content and the program itself.
Great, thanks Rosie, that's really helpful. So that's the kind of Samoa Cook Islands case study. I hope I'll now pass on to Rosie, back to Rosie on talking about text match.
So I'm going to talk about two examples that are actually based here in New Zealand that are a little bit different, but both are text messaging programs, and they're both targeting groups that aren't potentially being reached by our current health services. So the first is a maternal and child health program, which came out of some national Ministry of Health funding, but they were looking at how they could better support pregnant women and their families right through to a child is 2 years of age. the families or groups that weren't actually being supported adequately by a health system. So they weren't the ones that were engaging with maternity health providers or our child health providers, as we would expect them to. And so this particularly was our Māori and Pacifica communities, but also our new migrant communities, particularly South Asian and Asian groups that were new to New Zealand. So this, as you can see at the bottom of the slide there were a huge number of organisations that came together to support this initiative. And this was fundamental in not only the development and design of the program, but also its implementation and its success. So the process we went through, to develop the Text Match program is, as you can see, quite an extensive one. So we took direction from our Rupu Katiaki group, which is a governance group that was formed for this program. And it was made up of a whole lot of stakeholders from both our health service providers, but also the cultural groups that we were looking to support in this program. We also, which was really, really important, went out to our target audience. So we did focus groups and some sort of casual groups with women and their families from those 4 cultural groups, and looked at what would best support them. And coming back to that question that was posed that we were just talking about, actually what we found when we talked to these groups was that it wasn't always the case that people had a phone each. A lot of families were sharing a phone amongst them. And also that a lot of people didn't have access to smartphones or data. So straight away we knew we weren't going to be using any modality that required data, because we weren't going to be able to reach this group in the way that we wanted to. But also we needed to design an intervention that could be, it wasn't time dependent if someone didn't have the phone on them at a certain time, but also it was okay that other family members saw the content or received the program. So they were key considerations in the design of this program. The next step, once we'd got that direction and that guidance and the feedback from the end users, was to actually take what we already knew was essential in terms of information and support from this group. And we took national guidelines and national resources to develop what we called our key messages. And then, because we wanted to try and reach as many people in those target groups as possible, we then looked at developing that into a text message-based program, as I said, rather than using any, say, apps or internet or data-based interventions or modalities. All our content was reviewed by a technical advisory group for the project, but it was also reviewed by an external group of experts as well, to make sure that what we were delivering was not only evidence-based, but was really well aligned with the existing resources and support. Because what's really important with a program like a text messaging program is it's never going to be a standalone service. It really needs to sit within the wider health service and complement that. So the idea with this program was that it was encouraging people to engage with the health system in the way we would like it to, and for them to get the support they needed from the different services that were available to them. This program was a way of linking people to those services. We then went through a process of cultural adaptation, because right from the start we knew that we weren't going to be able to create a generic program that was going to meet the needs of all of those 4 groups. And after cultural adaptation, we then obviously reviewed that to make sure that it was still, the messages and the content was still maintaining the integrity of the initial key messages, but that they were appropriate for each cultural group. We then, guided by the end users, translated into the languages that they wanted. So rather than potentially using or translating into languages that our health service thought were the necessary languages, we actually went with what the end users felt was needed in terms of the different languages. And again, they went through review processes before we were able to actually insert those messages into our system and roll them out. So just coming back to those focus groups really briefly, they were a really essential part of this program, because what they did was they really showed us, what this program needed to look like, but also what it actually needed to say. And as you can see that, we weren't the languages that they wanted them translated in weren't actually necessarily the ones we were expecting, but that actually there were some really key differences between the group. And although the Asian group were really keen on the use of WeChat, a messaging app requiring data, actually for particularly the Māori and Pacifica groups, it was really clear that we wouldn't be able to reach them in an equitable way if we used a tool like that. And actually we needed to focus on SMS, which was far more accessible in the New Zealand population, but particularly those groups. What we ended up with was an intervention that was very much a support and information program, linking people into the services that could support them further during this time. But the program was completely tailored to them and their culture and their ethnicity, also obviously taking into consideration their language. And it was timed based on their child's gestational age, the gestational age during pregnancy or the child's age after birth. But also that there were separate messages if they were the mother or that they were family members, to make sure the content was as relevant as possible, but knowing that it was actually okay if a mother got a family message or a family person got a mother's message, because they were relatively generic so that it didn't matter too much there. And that came back into that, making sure that it wouldn't be a barrier if people didn't have an individual phone. And obviously messages as well were tailored, and you'll see that in the examples on the screen there, where there's terms in square brackets. That was completely tailored based on the information we asked from people at baseline. To make this program meet the needs of the population, what we ended up with was quite a complex looking back end, and that we had 16 different versions of the text match program. And so the data, the message library is actually over 6,000 messages. And as you can see, we have obviously the 4 different cultural versions of this program available in a number of different languages, but then there's also obviously a version for mothers and other family. And that we also make sure that in the English versions, we use appropriate cultural terms such as greetings based on someone's ethnicity. We did, we rolled this out back in 2014, and about a year later, we conducted a small number of interviews with people to see whether or not this program was acceptable and whether it was meeting the needs of the people we were trying to target. And what we saw was that actually people did find that it was relevant and culturally appropriate, and that it made them feel more supported during this time, and that they would recommend it to other people, which were really positive indications that this program was well received. So this program is ongoing. It's available today within the Auckland regions, and people sign up through cultural organisations, or they can self sign up to the program. And we constantly gather feedback on the program to ensure that it is continuing to meet the needs of our population. So rather than a one-time type evaluation, we have ongoing monitoring. And that monitoring is in the case of obviously looking at system-related data to make sure we've got consistent enrolments and not high dropouts at any time. But also we ask for feedback within the messages. We ask people to free reply with feedback during the program to let us know what we think. And we constantly get these types of messages coming in, telling us what people think of the messages and the program as a whole. And that's a way that we can continually monitor and ensure the program is meeting the needs of our population. Just to highlight, going back to making this program as accessible as possible, what we're able to do is work with the telecommunication companies and our gateway company to zero rate the messages. And what that means is people can free reply to this program without it being at any cost to them. We actually cover that cost ourselves. And then since the rollout of text match in the Auckland region, we've had interest from other areas of New Zealand, and particularly a region called the Lakes region in the North Island, where they have a very high Māori population, but also quite high rural, and again, with wanting to try and reach those people that aren't accessing our services as we would expect. And so we've gone through a process of not just rolling out the Māori version, even though you'd think that New Zealand's a relatively small place, we actually have seen quite significant cultural differences across the country. And so we've had to go and form local governance groups, work with local leaders and women and families to adapt the program, rebrand the program, and roll out the program down there as well. And that program down there is called Text Pepe, or Patuhi Pepe, which is the Māori terminology for a text baby. Okay, so that's a maternal health program, and I'm just going to talk very briefly about a diabetes program, again rolled out in New Zealand, particularly for Māori and Pacifica, and those that aren't accessing our health service in the way that we would like, or not reach the people that our services aren't reaching. And what we know about this group is that they tend to have lower technology access. So again, we're reaching a group that we can't go out with some really fancy technology. We need to look at what is going to be most accessible for them. So this is just the framework that we used to develop this program. As you can see, it's quite an extensive process of development and evaluation and implementation. The framework by Whitaker and published in 2012 has a number of steps that you follow, and it's a really useful guidance if you're looking at developing this type of program. But what is fundamental to it is that end user engagement throughout, as well as an implementation focus. So right from the start, again, we went out and spoke to the end users for this program. And in this case, it was diabetes patients, but also clinicians, diabetes specialists and dietitians and podiatrists and other clinicians involved in the care of people with diabetes, but also GPs or our general practitioners in the community who also engage with this population. We formed a Māori advisory group because this was a target group for this program. So we took guidance from them right at the start as to what was going to be the most culturally appropriate way to reach this group. And again, we looked at what's currently used in this population. We looked at DSME programs, as well as some of the technology that was being used overseas. And we actually explored a number of different things like telehealth, this is back in 2013, and remote monitoring for diabetes, as well as looking at whether text messaging was a way that we could support people with diabetes. What we then ended up with was an individually tailored and theoretically based diabetes self-management support program. And it was a modular-based program designed to be tailored to an individual person's needs, as well as the clinical characteristics of their condition and their preferences and motivations for good diabetes control. So as you can see, there's a number of different modules, and people can choose which modules are relevant to them and their stage of diabetes. And they receive personalised messages at times of the day that they would like. And this program did have a component of it that was timing dependent, and that was the blood glucose monitoring reminders. And for those people that did not have consistent access to the mobile phones or to the mobile network, we did have some people living rurally who didn't, and also some shift workers who worked in the mines in the South Island of New Zealand, where we encouraged them not to choose that functionality of the program because they wouldn't receive it at the times that they would need it, but they were still able to get other components of the program. This program incorporated a number of behaviour change techniques that we know from a theoretical perspective result in behaviour change, and particularly those that we know are fundamental to the success of behaviour change in diabetes. And importantly, by using text messaging in this case, we were able to capitalise on the fact that particularly mobile phones, but also text messaging is designed to be a tool for delivering social support. And it also acts as a prompt or a cue. So actually, just by utilising that modality of technology, we're actually incorporating behaviour change techniques that we know are going to be really useful. So after developing this program, we conducted a small pilot study because we wanted to know whether or not it was an acceptable way to reach this population. So it was a very small, as you can see, pilot study with people across just the Auckland region, again, specifically targeting Māori and those people that this program was designed to support. And that pilot study did show us that it was an acceptable way to reach this group, but also to support them. And so following that, we were able to get some funding to conduct a full randomised controlled trial to look at the effectiveness of this program. So leading on from the pilot study, we conducted a nationwide randomised controlled trial of 366 adults with poorly controlled diabetes. And they had both type 1 and type 2 diabetes, and anyone over the age of 16. And we had a huge range of people take part, ranging from the age of 16 up into the 80s. We had someone who'd had diabetes for over 60 years and a whole lot of people that were newly diagnosed. And roughly a third of the people in this group came from rural and remote settings across New Zealand, from the far north down to the lower South Island. And we also had a high proportion of Māori and Pacifica in this trial. And what we were able to see from the randomized controlled trial was that it was a significant reduction in HbA1c at 9 months in the intervention group in comparison to the control group. And so this was really basically evidence that this program was not only acceptable, as we'd seen previously, but was effective in terms of key diabetes outcomes. And again, we did still gather that qualitative information around the acceptability and the usability of the program. And we're able to see that this program was a really acceptable way of reaching these groups, but also that this program was providing those key elements of support that we were trying to reach or provide to these groups. In addition, I think just what's really important when we're thinking about evaluation is we also looked at the cost effectiveness of this program, because in terms of implementation, we need to know this type of data, and we were able to see that it was a cost effective program. And then we were able as well to look at whether the significant differences we saw at 9 months in the main trial were sustained at 2 years follow-up. And we saw positive results again there in terms of the people in the intervention group had sustained those positive changes in HbA1c. Okay.
So I'm just going to quickly ask this question of Rosie, because I think it's relevant to some of this work. We've had a question that literacy can sometimes be an issue with text message programs. And this person commented that they've used IVR in some contexts where literacy is a problem. And they just asked whether we weighed up these kinds of options when we were looking at our programs.
So one of the key things with text messaging and why it's really, really ideal in groups with low health literacy is that it is limited to 160 characters. So what we know about trying to reach people with low health literacy is that short key messages at spaced intervals is ideal for people to take on that information. So with the messages, we don't deliver lots of them in one go. They're getting one message at a time. And we do pre-test all of our messages with the target audience to make sure that they are obviously interpreted correctly and that they are appropriate for those groups. So we always make sure that our messages are designed. These are the groups that we're trying to reach with these programs, and hence why we're not using some of the more advanced technology. And I think a key component of targeting those with health literacy is the cultural adaptation process that we go through for both of these examples, but also the examples that Jude has talked about and Robin's about to talk about. So we do work with the cultural experts, but also members of those cultural groups in terms of end users to make sure that the messages are not only culturally appropriate, but are able to be or are appropriately received by the target audience. I think, there's a number of other modalities that we can use, and we have looked at, particularly for us, looked at pictures and using video messaging and picture messaging. And the issues that we've had with those is again around reach and access. So they typically require different types of phones or operating capacity within the phone or network access. And actually even receiving a picture message, there can be huge barriers in terms of that. And that's why we have stuck to the text message with a lot of these programs. But I think there, as you say, the person author of that question, is there's huge potential for other modalities as well.
Yeah, so thanks, Rosie. I think it's worth noting, as Rosie said, that it really depends on what your culture is, what your country, your community is used to using. So it's worth saying that IVR is not very common in a lot of our parts of the world. So we don't really use IVR very much in New Zealand at all, and it's not really used in the Pacific. So it wouldn't be an appropriate modality in those places. So as Rosie said, you've just got to find out what the technology is that would work best in your community. So yeah, hope that answers that question. So we've just got one more case study that we're going to talk through now, and then we'll go on to sort of some of our key lessons and how they line up to the learning objectives of this session. And this is just very brief, just to show you something a little bit different, I guess. So Ola Ora is the name of this project, and the difference with this is that this was very much a co-design project from the beginning, in that we had no fixed idea about what the intervention was going to be, how it would be delivered, what technology it would use, but even what the content was going to be about. So the idea was that the first step was to actually establish the relationships. And so we were very lucky to get the funding for this, and I will acknowledge we didn't lead this project, but Rosie and I did work on it with others. And so the group was very successful in being able to get funding for something when you couldn't tell the funder exactly what it was going to deliver, which is not that common. But that is how you do a real co-design project, and that it's all about the relationships first, and then you work out what those communities want. So we worked with a number of Māori and Pacific, Māori and Indigenous population of New Zealand, so Māori and Pacific communities living in Auckland and outside of Auckland as well. So we had 2 Pacific local communities and 2 Pacific community organisations, and 1 Māori community organisation and 2 Māori communities as well. And so the first steps were establishing those relationships and having the hui, the discussions around what did those communities actually want in terms of well-being. So the concept was just around a digitally enabled program that would help enable these communities to get to better health and well-being, basically. And so there was a lot of hui that were led by the community organisations, not led by the researchers at all, to ask those communities what did they really want in terms of what would help them to really achieve better health and well-being in those communities. And so a lot of work was done, a lot of workshops with a lot of very tactile materials to try and really get to the bottom of what it was that they wanted. So that ended up in a whole lot of different themes, many of which were things that perhaps we would have expected, such as physical activity and healthy eating, but also things that we perhaps would never have put in there, a lot related to family, extended family, spirituality, and also real connection to the story of their people and their journeys that they had made to get to New Zealand. And then we came in after all, as part of all that work, we brought our part of it, which was to show them what the science told us might work to help their communities in these areas. That's with these behaviour change techniques that Rosie has already mentioned. But also we showed them a lot about what kind of technologies existed, were out there, got them to play with them and to tell us which ones their communities would like and would be comfortable with. So the communities decided that they would like an app, that they were very comfortable using apps, and that they felt that they would get a lot from an app, a community-based app. And so we started to do what's called wireframing, where basically we would say, okay, we think this is what you've told us and what you're asking for, and we would just mock it up like on a piece of paper, basically draw it on a piece of paper and say, so you're saying this is the kind of thing that you want, this is what we think we've heard, and then we'd give it back to the community and say, is this right? And then they would have another go at that and say, well, yeah, that's kind of what we wanted, but didn't really want it to look like that, and give it back to us. So it's very much a circular process of iterating and iterating until we get to something that the community wants. And they start off looking very basic, then they start looking a little bit better, and then they start being mock-ups of pages. What we ended up with is a very beautiful app, actually 2 versions, Ola Ora, which means health in Māori and in Samoan, with some beautiful imagery. So it became clear that the imagery was very important to these groups, and the imagery around the journey that their ancestors had taken. And so that became a very big theme in the app, this theme of a journey that their cultures had been on, and the setting of the challenge, the wero, for the next generation basically were around being healthy. And so these were woven through the app, where as a community they would sign up to a challenge. It's not an individual program, it's very much a group program, which sits very well with the Māori and Pacific models of health, that these are very community focused. And the imagery there around the journey, around the wero or the challenges, and around earning something as a group, as a community, based on meeting these challenges. So I guess the interesting part around the co-design is that it was great in some ways and less so in others. One of the great things was that we really did get the whole community on board. They were very invested in this. And they really participated really well in the design process, and that meant therefore that they really participated very well in the cluster randomized controlled trial that we put in place to see whether it was effective. So recruitment was very good, very easy in lots of ways, because the communities were really involved also in recruitment and very invested in the app. But unfortunately it didn't result in a great behavior change as a result of the app. So while the communities were able to get people to sign up to join the trial, basically a lot of people who joined the trial still did not really engage with the app. And the result was that overall the cluster randomized trial showed that we weren't able to help them to achieve the behavior changes that we were trying to achieve. And there's lots of reasons for that, but when we really dig into the data, we can see that the subgroup that did engage with the app, which was quite a small group, but those who did engage with it did actually find it very helpful and did engage with those behavior changes. It was the group that didn't engage with it who did not achieve the behavior changes. So a really different kind of example, just to give you a different approach to the case studies. So those are the case studies that we're going to talk about. I'll hand you back to Jude.
Okay, thanks, Robin. So I thought what we might do now is go through some of the key. I'm actually going to jump ahead here. I'm going to go back. Sorry, not ahead. I'm going to go back to the original slide, which sets up our. Oops. Bear with me. Which sets up the questions that the whole program was based on, that the skill building session was based around. So what we wanted to do was identify some of the key indicators of whether a digital health intervention was appropriate as an adjunct or a sole kind of solution for meeting a specific or broader health issue. So in relation to that, I'd just like to perhaps elaborate a little bit more on the text message program in Samoa and in the Cook Islands. And one of the things that we really recognised was that, particularly with Samoa, and this was distinct in the Cook Islands, is that tobacco control was really underdeveloped. And so the kind of idea was, I guess that was driving in some ways the investment in an M cessation program, was could we sort of accelerate and really make progress by implementing a mobile and SMS program that could achieve what investment in other areas might achieve, for example. So we really were being, I guess, tasked with, seeing if we can invest the resourcing in M cessation. Does that mean that we're really also going to raise awareness about the risks of smoking and the importance of quitting? Does that also take some of the pressure off in terms of the requirements for brief behaviour intervention from health providers? Of course, what we realise, and it makes complete sense, is that the best way for these initiatives to be most effective is if they are obviously that they are integrated as part of a broader program of work. And in tobacco control, there is a number of factors we recognise are really important to supporting people to quit or not start smoking. So factors way upstream is so-called, so having a really clear expectations in the public service not to engage with the tobacco industry, and having really strong kind of investment in the WHO Framework Convention on Tobacco Control, all kind of dimensions of that treaty. So actually just investing in an M cessation program alone was never going to be a silver bullet here. We kind of could see that it was going to be best, do its best if it was sitting amongst and nestled within a broader program of work. What we didn't realise that came out of that initiative was that it was actually a catalyst to discussion about the importance of supporting and investing in smoking cessation. So across the Pacific region, smoking cessation is pretty, there's not a lot of investment. A lot of emphasis is put on people quitting independently. So Samoa is no different. But what we recognised when we had conversation with the Ministry of Health and the Health Service, so these are health providers and other civil society groups, was the more we had meetings in terms of preparing for the MC cessation program, smoking cessation and tobacco control was elevated on the agenda. So where it wasn't once before, conversations about kind of invigorating the tobacco control task force and trying to increase and review what's available for smoking cessation really was bolstered. And in fact, after the program finished, the pilot finished, a tobacco control, a smoking cessation bill was amended in the Ministry of Health. So that was kind of it was catalytic to that change. It raised the topic that it wasn't certainly an intended outcome, but it was a benefit. In Samoa in the Cook Islands, it was really different. There was a strong focus on tobacco control. Again, not a lot of existing programs around, but definitely it was a priority in country, and MC cessation was suggested as something that might relieve the very small group of people who are involved in smoking cessation and public health behaviour change, kind of enable them to do work to continue doing face-to-face counselling, while those who want to receive text message could receive it through that mechanism, through that modality. So that was really useful. But again, neither were a sole solution. Both had to be integrated as part of a broader program of work. And I think that's really, for us, was really important. So identifying what else is going on. It's really important what is not just going on currently, but what's being planned to come on in the future. Where does the heart lie, so to speak, in terms of the drivers of policy and intervention in the Ministry of Health. So if there are people in leadership positions who are really keen on investing in smoking cessation, that's great, and it would certainly lend itself to that. So ideally what we wanted to come away with for Samoa is a line in the budget, in the kind of Ministry of Health budget and in their tobacco control program that included smoking cessation. It may not have been mHealth. We weren't, this was an idea that was proposed, but it had to, leave behind an awareness that actually investing in supporting people to quit was really important. Do you have anything to add on indicators of whether a program is?
No, that's good. That's
okay.
Good.
So the next one I think is really picks up on what Rosie was talking about around SMS-4BG, but we're looking at some of the requisite key capabilities, Rosie or Robin, around and capacity needed to drive and sustain a digital health intervention. What would you say are really important if you're starting to think about, shall we develop an initiative that's based on a digital platform? What do you need to check in with first? Rosie.
I think similar to probably any type of health intervention, it's the stakeholder engagement right from the start. So before we're even thinking about implementation and sustainability of a program, if we don't have those key people right on board right from the start and involved in the design and development, it's going to be very hard to sustain the program. So, and those key stakeholders aren't necessarily just the people involved, sort of directly, but could be a wide group of people. So they might be people from, say, funding and planning from the health service. They might be members of the Ministry of Health. They could be clinicians or health service providers, but they could also be key community members or cultural leaders. So we found in a lot of our groups, it's actually the cultural leaders that can be really, really important to make sure these programs are not only taken up by communities, and particularly those that we really want to take up the programs, but also that they find a place within the the community or the health service so that they can be sustained. If these programs are developed just as something separate, it's very hard for them to be sustained within whatever setting that you're trying to sustain them in, because they're seen as a one-off and they're not integrated into the services. So Text Match is a really good example of that, whereby we had those organisations that we knew that would be key to referring people to the program actually intricately involved in terms of the design and the development of the content. So they were involved in and helping with making sure that the program was reaching the target audience, but they were also involved in the design of how we would develop and roll out the program. So in terms of how people would sign up and get onto the program, as well as what the program would look like, from little elements like the two-way elements of it. That was something that was always designed in conjunction with those people. And then from the diabetes program perspective, right from the start, as you will have seen in those early slides, we were engaging with a number of different groups and people who were going to be fundamental to the program's success. So we had people from funding and planning within a district health board, which is what we call regional sort of our health services here, as well as primary care clinicians involved in the design, and then obviously Māori cultural experts as well. So again, having these people involved right from the start means that we're able to develop something that has the potential to actually be sustained in the first place, because it's reaching the needs of the population and they see it as being useful. Yeah, that's probably the main thing from me.
Thank you. So it's just, we had, I'm going to sum up a couple of things from those 2 points that you guys have made, because we've had a couple of questions around suggestions for sustainability, which is really tricky. And I think that's the points that you've already made, that it's important to have the right people involved from the very beginning, so that they are the people who will be implementing it long term. So, and if you don't have those people on board from the start, then it's very hard to sustain beyond the end of the kind of the project people being involved. So that was a really important point. And I think, as Jude said in her first question response, I think ensuring that this aligns really well with the key priorities of the country and is sitting alongside other programs, so that it's something that those ongoing programs will continue to refer people into your text message or other in-health digital health intervention, because it sits really closely alongside the other programs that are going on. And that's worked really well for us with Text Match, because that's been going for 6 years now, because it's part of a much broader program, and the people on the ground in that program refer people into Text Match. And so that has enabled that to be sustainable beyond, you know, initial efforts. And I think that's got a lot, that's a good way of doing that ongoing promotion. So otherwise you have to have ongoing promotion of your program as well in order to keep it sustainable, and you have to have built in that promotional kind of program into your funding and your planning. For us, you know, being alongside other existing on the ground programs means that we get the ongoing promotion without actually having to do it ourselves. So that's one good way. I've
just got one more thing. I think something I learned from the Cook Islands pilot just recently that I didn't really think of when we worked with Samoa is the fact that actually a lot of the skills, like you think about mHealth or digital health, you have to be tech savvy. You know, it's all about kind of being good with you know, different digital platforms. Actually, one of the really important skills that you need in the team is being able to collect data and analyze it. So most of the really technical work, as in getting the messages out to people at the certain times, is actually, you have to understand, you know, that's an important component of it, the scripting of the messages and all of the front end. But actually having people able to do the baseline and the follow-up work as well and make sense of it, I think is really important. And often I certainly recognize myself that we miss that. I mean, the Cook Islands project, a lot of the work after the messages were adapted and we got them out and so forth, was actually keeping an eye on what people, you know, as the data comes back in. I mean, there's no point in continuing an cessation program if people don't like it and it is annoying them or it's not helping them quit. So being able to kind of use and draw upon those skills that we have as researchers or people use in terms of implementation science, whatever you like to call it at the time, is really important. Really, it's around listening, being able to keep tabs on and understanding what are the end users or the people who are receiving the program thinking about it. Does it sit as an awkward kind of adjunct in a program and something that dedicated team has to manage, or can it be integrated into a program and just be a different source of data that's coming in? And I think that the more streamlined and more integrated it can become, it's far easier to manage longer term. But yeah, I found myself spending a lot of time conducting interviews, collecting, the data, and Rosie certainly was very familiar with it. The data was a big part of it to determine the success, because the funders won't continue with an initiative if it doesn't demonstrate that it's fundamentally helping, and contributing. So those skills, I guess I would say I wouldn't underestimate.
And I'm going to throw this one back to Rosie, but because it's very much related to this question about requisite key capabilities and capacities to keep it going. These text message programs are actually they require very minimal resources ongoing to run, don't they? Because we've had a question here about, is there a special officer, I'm assuming they mean person, to handle SMS for BG, and what are the criteria there? So you talk about what resources run the programs.
Okay, so I think there is exactly something that gets forgotten when we develop these programs. So, and it comes back to the importance of having an implementation focus right from the start, and that these programs do need to be maintained and monitored. We can't just develop them and throw them out there. Even app-based programs, which you could argue don't need quite the same monitoring, still need to be updated and serviced, and to make sure that they're not only working as you want them to, bearing in mind that technology constantly gets updated, but also that they're still meeting the need, as Jude said. And so, for example, with the text match program, as you will have seen, there's roughly 6,000 people have gone through that program to date. There's approximately I think 1,500 people active on it at any one time. And we have, it's obviously free to reply to any of the messages. We don't encourage two-way engagement unless they are free texting the word stop to quit the program, and that obviously cancels it for them. Or if they're texting back feedback, or thirdly, if they text back to let us know that their baby has been born, if they're on the pregnancy program, and that triggers a switch over to the baby messages. So we're not encouraging two-way, but we do receive a lot of incoming messages into that system that aren't requested, and we do monitor those. So although it doesn't require 24/7 engagement at our end, we still have someone employed to check the incoming message logs daily, but also check that the system is working as we would want it to. So check that it is sending messages at the correct scheduling. We also have someone that is monitoring the referrals to the system. So obviously those referrals come in to us through different avenues, whether they're a person self-enrolling through a website, or whether it is community organisations and clinicians sending email referrals or entering them straight into our system. And sometimes it does require a person at our end to manage those referrals. So there is the requirement for ongoing support, but it is very minimal. We're not talking huge capacity, but I think it's really important that when we roll out programs like this, that we do have inbuilt monitoring into them, and that data is collected regularly, and that you have a process and a plan or a set in place from the start about how the programs will be not just monitored, but updated and improved. So we have to expect that programs will be, updates will be required, whether it be health guidelines change. In the case of text match and SMS-4BG, they link into existing health services. Those existing health services might change their contact information. Or in the case of diabetes, we had a national guideline change around insulin administration. And so we therefore had to change the content of one of the messages. So you need the ability, and not only the expertise to do that, but actually, be able to do it. So there might be the need for ongoing technical support, but also that content support, as well as just monitoring the system. So all things that you need to think about. And I think it's really important that that's considered right from the start when you're writing business cases to implement these programs.
Sorry, just
Does that
before
not
you,
answer the
just
question?
related to
Yeah.
that, though, another question about whether you're able to chat with an expert through the program. It's just
Yeah, so both of those programs have been designed in a way that aren't meant to provide clinical support. So they're not meant to be one-on-one individualized health care. They very much are seen as a support program to link people into the existing services. So when someone does, if they were to text in to try and talk to us, we would see those messages, but they would get an automatic response directing them to free health services. So we have national 0800, free phone lines that people can call with health questions. So there's a national phone line for sort of a generic health service. But we also have a child-specific one that we link to in those messages. So no, we don't provide two-way personalised support, but we are responding to people in an automated way that allows them to feel like they are being supported. In the case of the diabetes program, they can text back their blood glucose value and our system will automatically reinforce the behaviour of testing their blood glucose and sending in their value, but it won't provide them clinical advice as to what to do in relation to that value. So yeah, they're not designed to do that. We can develop those programs, but it adds a whole element of complexity, but also risk. So if you're going to develop a program that provides two-way interaction, and that's personalized interaction, you either need to have the AI behind that, or you need to have someone that's available 24/7 to do that. And that's very resource intensive. And what we know is if people are expecting a one-on-one personalized response, you need to provide that immediately. So you can't be doing that days later. So you actually need to have people there all the time. So it's a very resource intensive way of doing things, but absolutely possible. Does that answer that question?
thank you. Yep. Do you want to keep going?
Yeah, so all right, thanks. We're going to move on to the next focus for the session. And this is really was how do you design a basic work plan, or is there a design for a basic work plan for an SMS-based health intervention that takes into consideration what we've just been discussing? And actually, Rosie, I wonder if you can talk about text match, but also this might be a good opportunity for you to refer to the checklist that you have been developing that unfortunately is right back in the slide. So we'll scroll back through again.
Okay. So this is something I've been involved in working on. I won't claim it as my own. Oh, sorry about this. Here we go. Okay. So this is an example of some of the different things that you need to consider, I think, when you're starting off. And these are things that we've considered in all of the different examples that we've just given, but in different ways. So right from the start, it's about establishing the program or the project leadership and governance, and working to establish partnerships within the community or the health system that you're looking to work with. So in the case of the Pacific Island examples that Jude gave, those relationships of the local ministries of health and the local service providers were absolutely fundamental. And then with the New Zealand examples that Robin and I gave, it was very much working with the cultural and community organisations involved in these groups, these target groups. And then what is really important as well is that you conduct quite a thorough needs assessment. And so what's really important is that what you design and develop is actually meeting the needs of a population, because otherwise it just won't be sustainable, because if it's not meeting a need, there's no reason to maintain it. And so when we're talking about a needs assessment, we're looking at what the current situation is. So what are the priorities in that population or that area, as well as what the current, well, if you're looking at say a disease, it would be the burden of disease and the incidence and prevalence of that, but also what is the current knowledge and understanding of the condition. So, you know, in the text match example, we were working with mothers and their families to look at what their understandings of the different topics that we were covering was, and what were some of the cultural beliefs that might come into play in terms of engaging with the health behaviours that we were wanting them to. it's really important to look at what the existing services are. So look at what is currently in this space, because obviously you don't want to replicate a service that already exists. But primarily, or most importantly, we want to make sure that what we develop complements those existing services and those national policies and programs that are in place. And alongside that, if you're going to need training, you need to look at what training structure already exists and whether you can work in with that to make sure that the program will get out there and the people that you need to help support that program will be available. Obviously, the healthcare infrastructure may need to be investigated if you're looking at integrating into the healthcare system, looking at the specific target population and what groups or communities you are looking to first and foremost support. It may be that your program is available widely, but actually it was targeted specifically to some key groups. An example of that is the diabetes program, where we very much were developing that program for Māori and Pacifica, and that's why we chose text messaging, because we knew that that would have the most reach and access, whereas if we still made it available to all other groups within New Zealand, but we were very much designing it for that group in the first place because they were the group that we saw greatest inequalities in terms of outcomes of diabetes. You need to obviously consider the contextual environment and other, say, geographical components, and that Jude can probably speak a little bit more to the Cook Islands and things like that, where actually geography comes into play in the design and the development of these programs. And then what is really important in any mHealth program is obviously the country's capacity and mobile communication infrastructure. So looking at what is available, so device access as well as technology access such as data, the cost to access things. So in some contexts, SMS might be a lot more expensive than data, but in a lot of our settings, data is a lot more expensive and a lot less, has a lot less access as a result. It's also important looking at network providers. In some countries, you might have one network provider that is the only provider in that country, and so you can work directly with that provider. But in other countries, you might have multiple players, and that could have an impact because you really don't want to limit your program to people on one network if that could increase inequalities in your population. You do need to look as well at the regulatory restrictions around this type of thing. And then obviously what people are using. So I gave the example in TextMatch where our Asian groups were heavily using WeChat. And so that would be an ideal platform if you're delivering just to that group. Whereas if you're looking at targeting our Māori and Pacifica in New Zealand, it was really clear that SMS was the ideal modality there. Legal considerations come into play. Data is really important. If you're going to collect data through that mHealth program, is there some legal considerations you need to think about there? And also consent. So in some countries, you can just send SMS to anyone and there's no rules around that. But, it's really important here in New Zealand that people agree and consent to receive an SMS program or receive any mHealth program. We can't just spam them. And then obviously also making sure that all stakeholders, and I talked about this before, their views are taken into consideration in this, because if you don't take into consideration their views and their needs and wishes, you won't get their buy-in and they won't be there to support the program, which is fundamental. Obviously, if you're looking at developing a program, then there's a whole lot of work that needs to go into making sure what you create is obviously evidence-based and aligned with guidelines. And that's you heard the process we went through for the TextMatch program. So that actually took a long time. So it actually was a lot of effort and energy and time that went into making sure what we developed, went through all those different review processes, but also that cultural adaptation stage, translation and testing. But what might be more appropriate in a lot of contexts is the adaptation of an existing program. So we know that a lot of these already been programs are developed. And so if we're looking at adapting those, it may be that we can skip some of those steps, but look at how we can make that program culturally appropriate and relevant to the context that you're wanting to deliver it to. And so there's a whole process that you need to go through with that. And then remembering that obviously there's a whole lot of testing that needs to go into play as well, not just from our end, but also within the target audience. Obviously, Robin's talked a little bit, talked a little bit about promotion and how fundamental that is to these programs, but you need to be thinking about how the program will be promoted and who will be involved in that. And Robin talked a little bit as well, Jude talked a little bit about how it's really important if you're going to try and collect that data on the evidence of the program and its acceptability, you need to have a process around that and the support to do that. Obviously, as I said, you need to be considering the technology that you're going to use and a number of different elements that come into that around access, security, and how that will work in terms of scale up. So starting if you're just doing a pre-testing versus say a nationwide rollout. And then looking at whether that service and the infrastructure you've built, the technology will be sustainable outside, say, a testing or a small pilot. And if you were to roll out nationally, whether that's sustainable, but then also over time, if, say, healthcare systems or providers change. And then obviously having a plan of monitoring and evaluation right from the start. So making sure that's built into the plan. And there's different ways of doing that at different stages. So with the SMS-4BG example, you can see that the pilot was really around looking at the feasibility and acceptability of the program. From that information, we were able to adapt and refine the program to improve it. We were then able to conduct a full randomized controlled trial to look at the effectiveness. And that was really fundamental information for writing business cases for the program. But then with any of these programs, once it's rolled out or implemented to a wider population, you still need to be gathering that monitoring data, as I said with the text match example. Yeah. Does that kind of answer that?
Yeah. Thanks, Rosie. So I think that there's been a couple of questions which are kind of related to this section, so I'll just jump in there. One of them is around so there's two related questions. One is whether there's a difference between whether a program is seen to be sent by government or by someone else. And do we have any data around, who's the most effective kind of source to send it? And the answer is that we don't have any data around it. And it depends on your culture of your community. So it needs to be a credible source. It needs to be someone that people will respond to and listen to. But who that is will depend on the group that you're trying to target. And so often it is a government-related agency, organisation, or a health system, health provider-related organisation that they need to see it from, depending on what the program is again, but it may be that they want to see that it's coming from their own health provider or someone related to the health service that they go to. And sometimes they want to see that it's a credible organisation like a university or a CDC type organisation. But one thing that we have learned is that people do want these to be fairly formal. They don't want it to be to look like it's coming from their friend next door or someone like that. They want it to be someone credible and to be reasonably formal to go with that. But exactly who that is, you do need to kind of test that with your audience, I think.
Yeah.
And that, well, yeah, do you want to?
I was just going to add just one thing to that. I think the endorsement of the program is really important. So having the backing of, say, a Ministry of Health or a health service or whoever it is that as the primary deliverer of that type of health intervention in your communities or populations is going to be fundamental. So it doesn't need to be that the person believes it's coming from, say, a Ministry of Health, but having the Ministry of Health endorsement is quite important, that people know that it's evidence-based and it's best practice. And we saw that consistently with the text match example, whereby people wanted to know that it was New Zealand-based, evidence-based information that they were receiving, and that was really important to them. But when you actually ask them about who they think the messages come from, they typically think they're coming from the person that referred them to the program. So there's that link to that initial referrer in terms of feeling like the support's coming from that person, but the endorsement was important.
Yeah, I think something that's kind of interesting about this point is that actually without the Ministry of Health or whoever it is that's delivering, the program won't reach anyone anyway. So it might be designed with the community. It might be scripted in a way that certainly gives a closer kind of connection with what the community wants to hear and the way it's been framed. but you will find a logo somewhere on the screen, because essentially without that endorsement from the Ministry of Health or from whoever's funding it, it won't reach anyone. And that's one of the real challenges. And I think Robin's point about sometimes you can't assume who you think is going to be the right front organisation for an issue, and some interesting work that's been done in New Zealand, not particularly related to digital health, is that a lot of young Pacific women don't necessarily want to talk to or receive information from Pacific providers about sexual health because it feels too close. So sometimes getting a sense of, actually they want the messages obviously to have credibility and to be trustworthy, but sometimes they're not necessarily the right organisation. So that is that really important front end work. But actually, when it comes down to the pragmatics of programs being delivered and funded, the organisation who's paying the bill will want to be presented on there. And that's that important relationship you hold at the beginning, the community, the funder and implementer, and then the telco who's going to be working there. So it is, I guess it can't always be assumed. It's really important.
I've got one more question.
Yeah, okay.
You want to do that?
No, we don't. Okay, Robin, you've got a...
So one more question, which I think is a bit related to this section around the whole work plan, was around how much does it cost? And is it feasible for low and middle income countries to develop and implement these kinds of programs? Which I think is a really good question. And we could all probably say something about that. But one of the things that I wanted to bring up was the WHO Be Healthy, Be Mobile work plan, which is a global initiative to help countries to put in mHealth programs, particularly around NCDs, but actually I think it's got broader than NCDs more recently, and they do, as we've already said in that work plan, they try to make sure that you can get everyone in the room to start with, and that you are going to have the money to develop and implement a program before you even start, which I think is a good way to approach it. And then they will actually help. So they will provide these types of checklists that Rosie has just been showing you. They will provide those how-to booklets that have these checklists in there, and they will give you help to try and engage the right type of people to be in the room. And they will give countries quite a lot of assistance with some of the more technical aspects. They'll bring in external experts. They will bring in the telcos, the mobile network operators, people like that, to try and make sure that you get all of the support that is required before you start a program. And the other thing I think that that Rosie already kind of mentioned is that people shouldn't feel like they have to start everything from scratch, that there are already programs out there that can be adapted for local communities, and that is a much quicker and slightly cheaper way of doing it. It still takes some work. All of that, as we've said, all of that local adaptation still takes the work, and you still need to do it, but it will make it slightly more doable. And really, you know, we have done some programs on the smell of an oily rag.
Yes.
Yeah, Jude, haven't we?
Yeah, the last one was. And one of the things I think in terms of the emerging areas of that I guess questions we can't answer is how much do you need, or how far do you need to adapt, say, an SMS program from what we did with, you know, in the Samoa MCSation, which was absolutely everything, to the Cook Islands, which was taking it linguistically, adapting it, and pretty much rolling it out within a few months. You know, I guess I don't know, and I'm not sure if Robin or Rosie know about, you know, what is the key thing, you know, what are the core things? If you only had a small amount of time and a small amount of money, do you absolutely have to change in order to adapt? And the other question I think this also raises is absolutely, there are a lot of tools that are out there that you can adapt, and that's a really efficient way to work. But it is, I mean, sometimes, you know, the fundamental philosophy or the theory that those programs are based on might not always fit. So the behaviour change theory that sits behind MCSation is very much a sequential kind of, it's individualized, it's receiving messages to your own phone, and supporting you through that process of quitting and essentially behavior change. And what we're thinking about in this part of the world is perhaps, this is what Ola Ora probably picked up on, was actually, particularly with Pacific and perhaps Māori populations, things are not necessarily done for individual benefit. It's more of a collective family and social drivers that really matter. And I think sometimes the origins of a lot of behaviour change come from perhaps different cultural times and places, and may not fit. So I think adaptation is really important, but sometimes looking within a community or within a particular ethnic and cultural group and going, what matters, what really moves us to make difficult things, you know, to change behaviour. So there's some interesting work going on in that within our university at the moment. Rosie, did you want to add there?
Yeah, I was just going to come back to Robin's comment about the cost, and that we get asked this all the time. Like, it's probably the most common question we get is around how much it's going to cost to either deliver to certain people or to develop or adapt. Yeah. And I think the problem is that we can't ever answer that really easily, because it really depends on the context. And particularly when we looked at say the Pacific and going from Samoa to the Cook Islands, was that, you know, you've got a situation where in the Cook Islands there was a potential that the Ministry of Health already had a relationship with the telecommunication provider, and there was a potential that the telecommunication provider could deliver that for free as one of their services by the Ministry of Health. And if that's the case, you're removing a chunk of the cost there. But in some, you know, that didn't end up being feasible, but in a lot of contexts that's not. And actually we found that it was cheaper to deliver messages from New Zealand, and we've done this in the UK as well, haven't we, Robin, in terms of it's easier and more cost effective to deliver a program from New Zealand to these countries than it is to set up the infrastructure again. So that initial needs assessment that you do in terms of looking at what the infrastructure is, the capacity is, and things like that is really going to dictate your costs. And the costs could be really, really low, or they could be really high if you're developing a really intensive program like SMS-4BG that is, you're starting from scratch, and you're delivering, and when I mean intensive, I mean that, you know, large numbers of messages over a period of time. So people could have received huge numbers of messages there, and it was a very tailored program, whereas text match is a very simple program, maximum 3 messages a week, so very, very low cost in terms of the messaging, but also the infrastructure behind it in terms of the delivery engine. It's not delivering them at personalized times, they're set times, and a set scheduling system. So it really does depend on what you're developing and who you've got behind that.
Okay, got to carry on.
Yeah, so the last, the sort of point that we really want to focus on now, which I think is really, really important for any intervention, whether it's digital or otherwise, is thinking about what information you need to gather to evaluate whether this initiative has been successful. And in this case, we often think, is it being equitable? So we really wanted to be conscious and aware that it's reaching the people who need it most, importantly. So it's not just going to people who have the right tools and can access it, that it's effective. So it's doing what it's designed to do. Obviously, there's no unintended impacts, and that it's appropriate, that it's something that is appropriate for that particular issue and for the context. So with that in mind, I just wonder if we want to have a bit of a discussion about what makes sense. And you did mention some things in the checklist, Rosie, which were really helpful about the importance of, let's just think about it. Who are we evaluating it for? Is it evaluating for the benefit of the end users? Is it evaluating it for the stakeholders who are invested and think this is an awesome thing and is going to make a difference? Is it so thinking about the various dimensions of the evaluation, and just briefly with the Samoa, so the first thing you often want to think about is, did it help people quit? Designed an intervention or adapted in this case, does it make a difference? Do people who receive it more likely to quit than if they didn't, or had existing intervention or support? But in addition to that, I think because this was new, we also wanted to understand that process. So what did it take to develop and adapt this initiative, and what did people think about it? And that was from a range of different perspectives, not just people who used it, but also people who were going to be responsible for making sure it sticks around, have going to be involved in the longer term investment, and people at different sort of levels of governance and investment. So it's trying to think about, and often, you know, our funder wants to know whether it made a difference. Did they get return on investment? But also our funder, which was the New Zealand Ministry of Foreign Affairs and Trade, also probably were quite keen to know that we didn't do any damage to those important strategic relationships they've got between two countries. So we wanted to know that actually what we were doing and the way that we went about working in partnership was respectful, that it was appreciated, there was good involvement from everyone. So I think we were particularly conscious, because we were external kind of advisors. You know, this is a really delicate, it's a sensitive area. We needed to be really conscious of the fact that we weren't imposing our own kind of set of parameters and evaluation criteria, that actually you had that right balance. So my first thoughts actually is just making sure you're thinking about who the key stakeholders are. Rosie or Robin?
I don't mind, I can go next.
No, I'll just be quick. So just thinking about the Aura story that I told you about, the app and the co-design, and we had a couple of questions about this as well, is that, yeah, like Jude says, thinking about what you're evaluating exactly. So, you know, the co-design process was kind of a different thing from the effectiveness of the app. And so we potentially didn't really have the right evaluation measures really in the study. So the study main outcomes were around behaviour change, but really we probably should have separately evaluated the co-design process and what that got us and what the communities thought. So at the end of this, even though our research study showed us that it wasn't effective in terms of those behaviour change outcomes we'd set, the community still very invested in the app, loves the app, wants it to continue, wants to try and figure out, okay, so what is the best way to implement the app and to get it into the hands of people that will engage with it, that really want it and need it, and therefore to make the most of it. But because we'd done this research study that looked at just purely effectiveness outcomes in terms of behaviour change of a whole group, you know, a large proportion of whom were not really engaged and not really wanting to be part of the study, then, you know, we weren't able to really actively go out and try and get money to keep it going. So there was this kind of disconnect there between what the community wanted, what they wanted to evaluate in terms of the co-design process and the benefits of that. The benefits of co-design process to us as the researchers, having developed this great relationship with these communities who wanted to keep that going, and then, you know, the outcomes that we put into the research design. So I think, yeah, being very mindful of who are you evaluating it for and what do they really need to know as a result of this evaluation is really key and can make all the difference. And I'll let you talk about SMS for BG, it's a whole different story.
Yeah, so I think SMS for BG is probably quite a good example for the evaluation side of things, in the sense that we first up conducted a pilot study just to see whether it was acceptable or not. And the results of that pilot study, although it was only 42 participants, showed that this program was highly acceptable. And we did actually gather some HbA1c results, so clinical outcomes, but it wasn't powered to detect a difference there. But we saw some really positive things happening. And although you could argue that the program's really low risk, we knew that and particularly in New Zealand, that there's no way that a program like this would be implemented or rolled out without evidence from that was going to the kind of evidence that was really going to matter to clinicians. And so that's where we designed the RCT specifically to look at HbA1c. So looking at the clinical outcomes that we knew were going to be of most interest to the funders and the key decision makers. But also the outcomes of the evaluation or the RCT were very much dictated by the design of the program. So what we know in terms of what we were trying to do, our program logic, and what outcomes we would expect from targeting or doing, having that intervention, and then the behaviours that we are actually trying to change as a result of those key components. So HbA1c was very much the thing that we would expect to see a change from or change in that time frame if the program was effective. And so hence why we did do a randomized control trial, why we did look at HbA1c as our primary outcome for that, because that was what we knew was going to be important for a business case for implementation. Alongside that, we also knew that cost effectiveness was going to be key. In the context of particularly low resource settings, you're always going to need to know whether a program is cost effective, and so that needs to be considered in terms of any evaluation. And then also looking at the long-term outcomes in the case of the diabetes program was quite important as well, because we knew, well, we were told that people wanted to know that these differences were sustained before they looked at whether or not they should be rolling out the program. So it very much was dependent on the program itself. So we knew in that context we needed to do that type of in-depth evaluation in terms of a trial. But in the case of something like TextMatch, or in the case even of Ola Ora, the outcomes that are really important to the communities weren't necessarily going to be those clinical outcomes. And so for TextMatch, it's the ongoing user feedback, which is fundamental to the program being continued. So those end user experiences in terms of not only the end users, the recipient of the text messages, but also the community organisations that are feeling like the program is serving its purpose. So engaging women and family in a way that is getting them to improve the outcomes for during pregnancy and the child's early infancy.
So Rosie, can I just ask, what do you think it would take to get SMS for BG funded? Who do you need to convince, given its obvious
so as Jude has highlighted, the diabetes program is yet to be implemented, and is a really good example of how even when you do have the right evidence that funders have asked for, you don't necessarily, well, you're not necessarily able to get these rolled out. So we have looked at whether this program should be rolled out locally and done business cases within health services in the region here in Auckland, but also looking at national rollout and discussions with Ministry of Health and Ministry of Health here in New Zealand. But we're constantly up against competing priorities, and in a healthcare system which is strapped for cash, sometimes these type of programs aren't prioritised. And so unfortunately to date we haven't been able to implement that program. I say to date because we do continue to have those discussions, and I think I don't know what the answer is. Yeah. I think partly it is having champions in the key decision maker roles within the health service. If you've got someone at the Ministry of Health that holds on to the funding in a certain area on board, they're probably going to fund your program. Unfortunately, we did not have the head diabetes clinician at our Ministry of Health involved in this project. We did have a lot of diabetes clinicians, but they weren't the ones in the decision-making position. So I do think if you have those people involved from the start, their buy-in and their, if you take into consideration their perspectives in the design and development, you're probably more likely to get it rolled out, but there's no guarantees.
No. Yeah.
So we have a couple of questions from the audience that are related to evaluation. So we'll just put them in here if that's all right. And this is quite a good one. Behaviour change is connected with individuals' motivation. So just participating in an intervention can alter people's level of motivation, which is true. So when investigating the effectiveness of digital health interventions, how do we isolate this observer effect? So I guess our main way of doing this is through randomisation, basically doing a randomised control trial. Then we have a group who also get the attention of being in a study and who get to give us their baseline and follow-up data, but the only difference is that they don't get the actual intervention itself. So what we commonly find in a lot of our mHealth trials is that the control group does really well as well, when we don't even expect that they will. SMS for BG was the main example here, where the control group got usual care, but they also got interviews with our research assistants. And these were people who at the beginning of the trial had very poorly controlled diabetes. So just as a result of being in the trial, they really improved their control of their diabetes, and that was not expected, but that happens quite a lot in our trials. And so really the only way to to see how much of the improvement in your group getting your intervention is due to just getting some more attention from being in the study, is to do randomization so that you can compare the two groups where the only difference really is that one gets the intervention and one doesn't. And you assume therefore that the difference between the two groups is due just to the intervention. That's our main, right? Do you want to say something, Rosie? Yeah.
So just a couple, I think the control effects that Robin's highlighted, control group effects are huge. And I think you're absolutely right. People who sign up for these programs tend to be ones that actually want to do something about their behaviour. So the example of smoking cessation, you're going to get people that are already contemplating quitting smoking. But there is the potential that we capitalise on existing programs. So there might be text messaging used for things like appointment reminders within a healthcare system, or for other purposes, and we can piggyback on that in terms of getting people to contemplate other behaviours or other engagement with their health. So in another example of that is, say, the diabetes program. That is not a smoking cessation program. We don't expect people going into that program to want to quit smoking, but we know smoking cessation is a really key component of good diabetes control. And therefore, within that program, if someone is identified as a smoker, they will get messages that get them to contemplate quitting smoking and provide information for how they could access smoking cessation services alongside that diabetes program. So although it's potentially not for people motivated to do that, we can capitalise on the fact that this is a group that could benefit from that and help support pointing them in the direction of where that support could be. The other thing I think is really, really important with thinking about these programs is I don't think we ever see them as being the only program or sitting as being something that's going to be right for every single person in our population. And that we need to consider that hopefully these programs can set aside other options as well, whether that be, say, traditional print resources or traditional in-person services if you've got those, but ideally we provide option to people. I don't ever expect that diabetes program to be the program that's going to meet everybody's needs, and there's going to be people who want to do things differently, and that's okay. It's just making sure we wouldn't design it if we weren't still reaching a population that did need it and want it.
So, and another question we've had is about cost effectiveness. And cost effectiveness is actually really quite hard to do, but basically, so for example, the smoking cessation programs are probably one of the easier ones to look at, because we know the benefits, the cost benefits of stopping someone from smoking. That's been very well researched. So we know that if someone gives up smoking at a certain point in their life, we're going to see cost benefits to the health system further down the track, and those have been quantified. And then we can look at the cost of providing the text messaging program as compared to those costs. And so we have done that, and text messaging for smoking cessation is probably one of the most cost-effective programs that any health service can provide. And we can also compare it to other ways of providing smoking cessation, because most countries will do something like a quit line, and we can cost how much it is to run a quit line, which is actually fairly expensive because it's people resource to be available on the phone. So that's probably one of the easier ones, but some of the other programs, it is, reasonably difficult to actually measure cost effectiveness. And also, it does depend again on the context, because it depends if that country is doing something else that is effective in that area or not. And so some of the programs that we have introduced are, they are an added investment, because it's not something, we're not replacing an existing service. It's something added on top that we are asking the Ministry of Health to pay. And then we have to try and measure what's the added benefit of our program compared with, what they're already doing. So that can be a little bit tricky to convince ministries of health that this is worth the added investment.
What about the issue, Robin, of scale up? I mean, sort of cessation's cost effective when you deliver it at scale to all, or at least all smokers have access to it. I mean, as opposed to having, I think this is one of the challenges with these pilots. I mean, they're really important to test its feasibility and its effectiveness. But there's always the lingering question, would this still work at scale when it's delivered to a whole population or a whole community? And we've the cost effectiveness assessment we did for the cessation program in Samoa did which was modelled on, delivered at a population, certainly demonstrated good cost effectiveness. That was no surprise. But again, it's very difficult, and that's what the Ministry of Health wanted to know. Essentially, we had to very early on, when we were having discussions, think about what would this cost if you removed all the sponsorship and all the work that we're putting into it. What would it cost if it was delivered by the Ministry of Health in Samoa? And could you comfortably say that that added as much value if they were going to choose an M cessation over something else, which was often, you know, the reality really is not, here's something else will add to the situation. It's like, can we invest in M cessation, or we do brief intervention training for health providers. So they're the kind of, I mean, really important information, but not always straightforward to gather. And it requires, again, for us in terms of that technical expertise within a team, is having someone who can do that modelling to demonstrate and then hypothesize, I guess, what it would look like if you remove all the other investment that is delivered through a grant or support externally.
And which is really important to do. So there's a couple of things there. One is that these kind of digital interventions should be much more cost effective at scale than almost anything else, because there is an investment up front to get them up and running. But if you only had 10 people engaging with them, they'd be really expensive. But if you had 100,000 people engaging with them, it's not, you know, 100,000 times more cost. It's you know, marginally, you know, more cost because it's being delivered digitally than if you were trying to deliver it, for example, in person. So that scale should be important, but as Jude says, it's quite hard sometimes to do that work, but it's very important to do that work to show the ministries. We've had another question here about sometimes the buy-in of local government is the key, you know, thing, and can be quite hard to get if a government system is very habituated to a paper-based way of functioning and not open to digital health interventions. And so it's really important to try and do that work up front to show them how it can be actually in the end much more cost effective for them.
I think that's a really good question, and I think it brings us back to one of the challenges we faced with Samoa project right at the beginning was this wasn't an idea that came from the Ministry of Health or the CEO of the Ministry of Health in Samoa. It was an idea, in a way, a concept that we came to them with, and I think that's a really important difference than, say, when we worked with the Cook Islands, who the team or the Secretary of Health came to us and said, look, we'd really like to trial this. Can we work together and see whether we can deliver this in the Cook Islands and build the capacity and the capability to run this in the Ministry of Health going forward. So I think sometimes that, I'm pretty confident that it's really important to have, you know, there's no end of great ideas that come from other places to solve problems, and it's one of the uncomfortable kind of you know, reflections about this particular project. It was really something that we didn't, let's say, kind of need to do a lot of convincing, because the kind of core baseline criteria was there that Samoa had a high proportion of people smoke. They were and, you know, use their mobile phones. In fact, the Ministry of Health was very enthusiastic and wanted it to start almost immediately. The fact that it took some time to develop and implement, you know, is just part of the process. So I think really that point about absolutely you've got to have people at the most influential level really into it. They don't have to spend all their time on it and be up to date with everything about it, but they have to believe in it as a concept and its ongoing value and contribution to strengthening a health system, not just to deal with the tobacco problem. It has to be part of the health system going forward. And I think one of the exciting things when we used to go and have conversation was the thinking that we'd have, or the discussions we'd have about the potential for using digital in other areas. They could see value if this worked for smoking, well, why not could we use it for other, in terms of maternal health or you know, hygiene, sanitation. So they could see the, you know, the potential. But in reality, when health systems are really fragile and under pressure, and there are major changes, and in this case in Samoa, went through a massive restructuring of the whole health system, the infrastructure, you know, these really are not going to stick around. They really have to require somebody who's incumbent to really champion it all the way through, because there isn't any, I hate the term, but skin in the game. There isn't any investment from the organisation, from the ministry at that point. It's come from a grant with enthusiasm and support and goodwill. And that goes some of the way, but without that in-country really strong investment that they recognise that this is what's potentially going to add value to their health system and meeting their health targets and so forth, it really is a hard push. And we have such good evidence of, I mean, many examples of great pilots that just, you know, have not gone further. And I'm reluctant to blame the governments for not picking them up. I think it's the way that they were often conceived and that timing and the fact that, you know, sometimes inadvertently the just not quite the right people around the table at the beginning. And we're really, I think, much more aware now of earlier errors or just oversights perhaps, and learning in this field to think about some of those risks about, you know, evaluating benefit and sustainability. So that's a good question.
So we've got quite a few more questions.
Yes.
Do you want to work through them?
All right, so maybe, shall I? Do you want to switch in a bit, Rosie?
I'll come in when there's questions.
I don't want to see.
Well, this one's just quite a good suggestion. For a low-income community, it would be nice if they were rewarded a 30 minutes free internet daily nationwide with related websites, pages that they can surf to seek information about health. Can this be implemented?
Wow, that's a good one.
I think the answer to that is ideally yes. That's a great idea, and it is actually possible in the sense that there is the ability to. I think Robin has taught me the term is whitelisting. That actually websites can be made available free. And that is happening in New Zealand at the moment around COVID-19 in the sense that related websites were made accessible to everyone. So there was no cost to access them, no data requirements. And so that could be part of the plan, and that could be put into the budget right from the start, that you want to provide certain resources free during the program. And so, yeah, absolutely possible. If you've got the budget to do it, fantastic. And I think that's really important. If you're trying to reach people that are who don't have great access, say data access, and you need them to link into different services, you're using something like text message that is not going to be enough for people, then making sure they can access the required services free is going to be really important. So obviously we have a public health system here in New Zealand. So when we're telling people to link into their doctor, we know that they're able to access that for free, but that wouldn't be the case in some other contexts.
Great. And just related to that, another question about the text messaging and costs and things. So yes, you can what kind of reverse the charges of text messaging so that people can send you in a response by text message completely for free. So even if they have no credit on their phone, they can still respond to a text message with another text message. So that does help get around some of the costs as well. And yes, we always have a ability to unsubscribe. They all just have to text in the word stop, and then they will cancel their program and they will stop getting any text messages. So that's a really important thing to do. And sometimes we don't tend, as our group, we don't tend to run like an 0800 free number alongside our programs, but we will have in there, you know, who they should go to if they have more questions that they want to talk to beyond just sending us a text message. So for example, with Text Match, there are phone numbers in there of free helplines for various things so that they can ring someone for free if they want to get more information. So that's kind of answers that question. So when considering the culture component, what other factors did you consider apart from language to design these programs?
I think absolutely there's so many different elements of culture that we consider, and that if you think about the text match example I gave, it was sitting down with members of those cultural groups to look at not just, you know, their language preferences for the delivery of the content, but Also, what are the foods that they, common foods that they eat, exercise types, what are the beliefs around pregnancy? So there were some really specific cultural beliefs and practices that we needed to consider, maybe to talk about in the messages, or just need to consider in the context of delivering messages. So things like grandparents might be more involved in bringing up children in some cultures versus others. Jude touched on the fact that, in some of the cultures like Pacific and Māori cultures, there's a lot more of a collective approach to health. So the whole community or the family are involved in someone's health more so than it being an individual's decision or process. So individual behaviour change programs aren't going to potentially have as greater uptake or relevance. So there's lots of different things that we take into consideration, and that's really important right at the start. And not only that, but in terms of what we talk to people and get their thoughts about the design and the content. But if we go back to the theoretical models that we use in designing these programs, so we not only use, say, a common behaviour change type theory, such as social cognitive theory and underlying the design of the program, but we also consider cultural models of health. So there's every culture probably has different ones, but we obviously, when we're working with Māori, we'll work within common Māori models of health in terms of designing how this program might look.
I'd just also add, I think one of the developments that is I'm hoping to see and is sort of starting to come through more now is actually not, we talk about co-design and working with other cultures, actually, helping. I think one thing we could add, and that's useful, is helping build those skills and capacity for example, Pacific leaders to design and so there isn't kind of a translation process. And I think that's something that's really was distinctive, I think probably more in the Cook Islands program, is that really we as non-Pacific and non-Māori, this is not for our community. So our role in terms of being able to kind of usefully design and add value there is very minimal. I think we can support that process, and often it's that sort of, whether it's co-design or actually conducting focus groups, or in different Pacific contexts, it's talanoa, which means that group discussion. I think that's where I think as non-Pacific or non-Māori or non-specific cultural group that we, can add value, because really I think having it designed by and for the group who's receiving it is most adds greater credibility. So that's really important, is knowing where we can add value and where actually we can't, in terms of making sure that those programs are culturally adapted and appropriate.
So this is a really tricky one, Jude.
Yeah.
One of the biggest challenges in digital health technology implementation in LMICs remained limited to the standardisation of information in order to communicate across facilities and stakeholders, particularly in countries like India, where there is a large private sector and each individual private provider has their own digital application, which don't necessarily talk to each other, and there's no way of communication with government data systems to deliver integrated care using digital health remains a huge challenge. Any thoughts on this?
Well, I just think, like we've seen with the COVID situation, COVID-19, I think, integration, collaboration, communication is incredibly important. It just goes without saying. But I think the interesting thing that your question kind of hints towards is that actually there is considerable private investment interest in digital initiatives, because for good reasons sometimes, and sometimes reasons that have greater benefit for the organisation, the funder. So corporate sort of social responsibility drivers to investing in mHealth and digital health sometimes has helped sort of propel this area forward in ways that isn't always useful. So I think that is a challenge. I think certainly the context of India, which I have no experience with, but I can only imagine there is competing and sometimes conflicting approaches to, and it's a competitive market. So there is, I guess, a sort of a democratization of health information and initiatives and interventions. And buyer beware almost in terms of what you take advantage of as a consumer in terms of these tools and that are available. There is no answer to that. I think you're raising a really big challenge. I think the area of digital health is exploding, and I think there is a lot of trialing of new ideas. Some of them are quasi-commercial, some of them are purely public oriented for benefit of improving health outcomes. So, I think one of the things that's always useful is to map, what is to this best you can, figure out what's going on. But I don't think I can't imagine there'll be a situation where everything has to be, Rosie and Rob, you might add here, it's been organised neatly.
I think, I think it's a fantastic question. I think absolutely it is extremely challenging and not easily answered. And I don't know if this is really answering the question, but I think the potential of digital health is that we can create quite a generic program that can be tailored. So if we think about, so not taking away from India for a moment, to say just the example within New Zealand is that we can be providing a text messaging program, but depending on where someone lives or depending on their health service provider, be providing the information for that particular person. So, by using tailoring, and it's completely automated, you can be pointing people in the right direction. And another example that we didn't talk about today is another program we provide, which is multimodal, where there is an app component. We know not everyone has access to the app or has access to data, but if they do, the text messages actually point them to the app. But if they don't, they don't. So we're able to tailor the content of the message based on the support services or the technology that they have access to. In the case of where there might be completely different providers, in the case of, say, India, I think what we've learned to date is that sometimes trying to reach everyone or a whole population is actually just not feasible from the start. And you're kind of setting yourself up for failure, or it's just going to be too challenging. And that actually starting small, so starting with one health service, one community, and building momentum will then allow you to grow and work with further areas. And so there's no harm in starting small. I think the ideal is that we provide national services. They make total sense, but that isn't always feasible or possible or even sensible.
So I will give you one example from India, and it does answer another question as well. So not that we are anyway expert in the Indian situation, but I did work with the WHO when they implemented a national smoking cessation text messaging program with the Indian Ministry of Health. And so what we discovered in that is that the Indian Ministry of ICT actually has a really good system for sending out text messages that they had built and that they can do nationally. They also have the ability to email anyone in the country who has had any interaction with any of the government websites and has left their email address. They are actually able to email them. So actually doing a national program in India, in some ways, some of the barriers have actually been addressed, in that the ministries worked together to send out a national cessation program being promoted through those government websites, email addresses, and through a government platform. So they were able to do so, and so this was probably 2 or 3 years ago now that they set this up, and they within a couple of months had 2 million people had signed up on the website, and then they introduced an diabetes program after that. Now, there were issues around this. They used the callback system where if you want to register with a program, you ring it on your mobile phone and you hang up within 2 calls. And so you don't get charged for that call, but on the far end, the ministry then gets your mobile phone number, and so they can register you in the program and send you a text message. And that worked really well. It's very easy, but they did end up registering a whole lot of people who actually weren't very clear what it was that they had signed up for. And so a whole lot of people did start the program and then come off it, because once they realized what it was, they weren't interested in giving up smoking. Some of them weren't even smokers, but they were just doing it out of curiosity to see what it was. So in some ways they have got around some of the barriers of implementing a national program in India. Don't know if that helps with your particular problem around the private providers or not. but that is an example, and it has been published for the other person who wrote a question around showing that SMS programs can be done at scale and are sustainable. That is a good one to look at, because it has done at very large scale and it is still going. So it has been in place for a few years now. So that answers that question as well, I think. We've got some really good questions in here. Here's one. Digital technology is no doubt an innovative approach for behaviour change. My concern is whether these SMS can attract all categories of population to read the SMS attentively and understand the key messages. Sometimes we ignore many SMS that come to our cell phone. How can we ensure that people will actually read it? That's a really good question. Yeah.
Oh,
I don't know.
So I think that's an excellent question, and there's a couple of things to think about there. So sometimes actually the beep or the alert or the message actually coming to the phone is a technique in itself that can act behaviour change. And we know when we've talked to people that they'll say things like, I don't have to read the message. I know when I hear the beep that it means that it's probably time that I do test my diabetes or something like that, or that it's a prompt that they can then process in their own way without actually having to read the information. Obviously, it's ideal that they read the information, but we know that that's not always going to happen in the exact moment, and that's okay. And I don't see a text messaging program being the perfect solution for every single person in our population. And the most common reason that people text stop or withdraw from the maternal health program, the text match program, is because they find it too simplistic or it's too basic for them. And those are the people that are generally quite health literate. They have high access to other resources and support. And so we don't actually need to be supporting them with this type of program. So I think we don't see that as something that every woman and family member in New Zealand should sign up for in their region it's provided. But it's specifically for those people that need it or it's been designed for. So being okay that it's not reaching everyone is probably the point that I'd like to get across.
Yeah, good point.
Yep, this is probably another one for you, Rosie, because this is about, in particular, around marginalised or stigmatised populations. Sometimes content may be sensitive, such as around sexual behaviours and things. And is there any particular special approach in these sensitive areas?
I don't probably have one answer for that. I think there's a lot of consultation that needs to go into working with the population in the first place to understand how to do this. I think in cases where the population do have their own mobile phones and there's no risk of someone else getting hold of those, you can deliver the messages, but making sure the start of the messages are a code word. So not starting the message with, congratulations, you're pregnant, or around your upcoming abortion, or using words like that could trigger someone else glancing at the phone to become interested in what's going on. But we used to, or topics even that are a little bit more sensitive, you put something at the start of the message which is long enough that when the alert pops up, it doesn't provide any of the detailed information. The other thing to do, and we do this around the family violence messages, is to make sure, so in the maternal health program, is to make sure that those are the messages where we don't use people's names to imply that they're the ones that are, so for the family messages, that they're the ones enacting the violence. We make them quite generic, so they're less threatening. And what's really important is that in messages like that is that they're still really positively framed. So we're not looking at blaming people or triggering things in that way. It's very much a supportive, positively framed message. I think if you're going to use something like text messaging for really sensitive areas like, say, abortion, I think there'll need to be good justification for that modality, and it probably will look quite different to the kind of programs that we've given today. So it may be that isn't the most appropriate technology. If it is, there'll probably be a lot of caveats around that, and that's going to depend on working with the services and the target population.
Yeah, the questions are rolling in, so we'll keep going as long as you're all still there. There's a question here, it's been for a while, maybe we've answered it already. Do we think that this works only for a group who are already active with the technology, and will we lose a group who are not familiar with technology? No, you go. No, I mean, we did start by saying that, you know, that we do that work with the target group up front to find out what technology they are happy to use. So it's not just what they're already using, but it's what they're happy to use in terms of a program to do with their health, and also that they are confident using it. This is the other thing that we really are interested in, whether people are confident or not. But it is possible to, if a technology is widespread, it is possible to teach people, of course, to use it too. So text messaging is available on every single phone, and regardless, as we've said, of credit. And so we do get some older people who are not very confident in using things like text messaging on their phone if it's not something that they're used to doing. But it doesn't take long to you just have to invest the time to upfront in person generally to go through it with them and to show them how to do it. And then they become quite proud of themselves that they are interacting in this new way.
Also, sometimes messages are shared, aren't they, within a, so while thinking about older people are not as sort of familiar with using digital tools, and some of the work we're doing with older Pacific population or groups here in Auckland is the messages are sort of sufficiently generic that actually they are kind of shared within, so they might be picked up by one of the children and shared with the elders of the family. But Rosie, do you want to add to that?
Yeah, I think that these programs in themselves can play a role in increasing the digital literacy of the population. So I think in that needs assessment, it's really important to understand the digital literacy of the group, not just, I suppose, the digital literacy, but also the digital confidence, which Robin highlighted, which is a slightly separate construct, because particularly when we're working with elderly groups, they could actually have quite high digital literacy, but they might have very low confidence. So although they potentially know how to engage with it, they don't, because they're not confident in how to do it. But we can, as I said, play a role in helping to increase that, and that may be around the education that sits alongside the program, or the referral pathway, or who it is that is engaging that person to sign them up, and they may play a part in that, or whether the program itself delivers some of that digital literacy training in the content. The other thing to think about is when you do assess the digital literacy of your target audience, is that the program that you design matches the digital literacy, or the lowest digital literacy. And that's why programs like the Text Match program have been designed to be one way, largely, because we know that therefore people aren't going to miss out on content because they're not able to, or they don't have the ability to reply. And so when programs are dependent on people engaging in a certain way, we have the potential to lose them unless the training is there. So something that needs to be considered right from the start, but it shouldn't be a limitation in terms of designing these programs.
What about the use of, so we're thinking a lot here about SMS and text messaging as the kind of modality. What about social media sites that I'm thinking sometimes, particularly again amongst specific populations, families, they connect with each other across the islands, not so much through text message, but often through WhatsApp particularly, but also Facebook. And we're really curious about the value that might add to having a greater reach. So you're part of a community group, it's organically sort of generated group, it's a community group of which this kind of messaging can be not targeted and personalized, but maybe have collective value, and by having that can actually have greater credibility. So there is potential there really to explore social media sites.
There is definitely, and again, it just does depend on what is commonly used. And as you say, in the Cook Islands, it is Facebook. And so that's what we're going to explore. But there's not a lot of research evidence backing that up as yet, other than in China, where they use WhatsApp, because it is just so widely, WeChat is so widely used that we have some researchers have been doing our programs in WeChat, and that seems to be getting very good coverage. But not a lot of research evidence as yet. But and I guess the research evidence of does this, if we're looking at behaviour change, does receiving messages through a social media platform like Facebook have as much kind of impact or
sort of effectiveness as receiving it through a personalized text message. And
Yeah.
that's the difference. We know that they're popular and they're widely used, and they're often used for connecting and, you know, populations, but actually in terms of the conduit for behavior change or social change, it's not as clear.
Just a little bit related to that before you go to Rosie, because she might have to answer this one as well, is we've had someone say sometimes in low and middle income country setting, patients are only satisfied when they see the doctor in person. And so how can we do these kinds of interventions when that's the kind of cultural approach in these settings?
It's a really hard question.
That
Basically, I think if that's the case, it's going to be very hard to start off with a digital intervention. And it may be that the mHealth program sits after that initial consultation. So it might be that there's a face-to-face consultation, and then that person, that clinician, is the one that signs them up and triggers the mHealth intervention. And by doing that, the mHealth is linked to that in-person consultation. So you're reinforcing the in-person support using the mHealth. I think it's very, very hard to engage in population, I suppose, cold turkey, going in there without any relationship to start with, particularly if it's a culture where they're very dependent on that relationship. And I think, yeah, Robin's right, that kind of does relate to the previous question, and that person can play a fundamental role in ensuring the mHealth intervention is appropriate for the end user's digital literacy and you know, ability, as well as their access to technology. We don't want to be offering something to someone that they can't access. And what we know is that, you know, even we've had a really high interest in sensors being used to monitor and provide feedback to people, like your Fitbits and other wearables. But one of the big issues with that is people knowing how to charge them, particularly in a group that where digital literacy or knowledge is low. The other one is logging into apps. So, you know, one of the biggest barriers to engaging with the Ula Ora program was that they needed to remember their password to log in and have an email address. And those are the kind of things where actually that in-person clinical, or, you know, first contact will be really fundamental to ensure the person can access it and use it in the way it's designed, as well as providing that key personal contact that might get or motivate the person to engage correctly.
I'm just going to add to that, Rosie, because I'm just thinking about almost like feels like a slight revival of telehealth, which feels like it's been around for a long time, and certainly in this part of the world, it's in terms of connecting the remote islands in the Pacific region with some of the kind of hubs of where some of the more capacity is. Like, feels like there's real potential for that as people become more familiar with telehealth, and that's not just clinician to clinician across, but actually, and we certainly experienced that in New Zealand and in many other countries, I'm sure, that with COVID-19 lockdown, where we couldn't go to our doctors as easily, and you had the potential for consultations online. So it feels like this is, as Rosie said, sometimes leaping straight into digital might be a step too far, but actually sometimes maybe, telehealth might have a role to play.
It's a really good point. Absolutely, Jude. So this is another really tricky question. We're asked if we think this could work in a country that suffered from multiple challenges of poverty, war, disrupted infrastructures like Yemen, and what is your advice to advocate for digital health in this situation? Obviously, we are not experts in dealing in that terrible situation ourselves. So really, all I can say is that, text messaging may be actually, the only thing that you can still do in a situation like that, because requires the least amount of infrastructure of almost anything, and the least amount of burden on even a mobile network that may not be working very well. But mobile network is likely to be one of the last, bits of infrastructure that is still standing everywhere, and text messaging has the least burden on it, and so is usually still allowed regardless of what's happening. So we've seen in situations like, really natural disasters like in Haiti and other places, that text messaging was one of the few things that they could continue to use until all the infrastructure was back up again. So
would you also say, Robin, again, but I wonder, again, this is an opportunity. So text message, absolutely, it seems like it's one of the the last, or the most resilient in these really fraught environments in that regard. But also I'm wondering again about the benefit of social networking is really important in terms of community resilience and hope and accessing services. And again, thinking about the potential for social networking sites that, if they're still accessible, again, that has that collective broader reach potential, that individualized text messages where you still need the numbers to be embedded into a system, and that follow-up. I think that's certainly, in terms of the investment level, it's one of the lower ones, but actually one of the things is using existing networks that are already operating collectively in a society, that are already functioning to serve other purposes. So jumping on board with those where possible and not risky has potential as well. If you're not going to, again, much harder to monitor the impacts, you don't have the nice baseline data and so forth, you are really going to be evaluating along the way. But it is possible, and there's some good free online software to monitor and look at some of the comments and impacts of messaging and support provided through social media platforms. That's available again and perhaps possible to use.
Yep. I think the only thing I'd add to that is that obviously mobile technology is really ideal for when populations are moving for any particular reason, whether that be in the disaster situation or any kind of conflict. But people's address is, you know, and in-person care is going to be really difficult, and actually mobiles will likely be the thing that they're going to carry with them. So it can be an opportunity to provide more consistent care than we can provide in any other way, or provide follow-up. And also obviously that the text messaging being, as Robin said, the lowest common denominator, I suppose, of the mobile health modalities, means that it potentially will be the most accessible tool that we can use. And it also potentially allows us to provide some type of intervention where it may not be safe to provide any in-person care or send people in. And then we've seen that in places like Papua New Guinea and places where they're not able to get services or the same kind of healthcare services, but text messaging does provide opportunity to reach people.
Great. Okay, we've got some more questions here. Some we might be able to do relatively quickly. We've had one around the scale question again. Relying on public sector for eventual uptake may not be the most feasible given competing priorities and issues in domestic spending on health. It's very true, and we've shown that we have that issue ourselves with our diabetes program. And so it kind of leads you back to one of the previous questions about private industry, and it very much is contextual, but we see in the US, for example, a lot of the large scale digital programs and text messaging programs are actually from private providers and from insurance companies, and they are very widespread, they are very large scale, and they have been sustainable over many years. So it is possible, you know, that private companies, you know, kind of behavior change support type companies, we've seen it in pharma. So some pharmaceutical companies have these type of programs alongside their products, and we've seen it with insurance companies doing these kind of really large scale programs. But then also still in the same context in the US, you know, the National Cancer Institute runs their national smoking cessation digital health program. So you know, both are possible, and it's really, you know, you've got to get the money and the support from wherever you can, really, in a lot of countries, depending on what is available. So not an easy answer to that question, but we've got another question around, did we come across issues of data security and patients' personal data protection in our pilots, and how do we deal with them? And we did pretty much deliberately try not to put any really personal health data into our messages. And there are ways to do that and yet still make it feel quite personalised, aren't there? But yeah, there are issues with including personal information because it's not secure. It's not a secure method.
Yeah, good point.
And I think that also comes back to the question before about when you're dealing with sensitive topics. And one of the, I think, benefits of some of our programs to date has been the fact that they don't collect any personal information, but they also don't require a lot of detail for people to sign up. So we're not asking them for even their legal name. They can give us a nickname or a preferred name that could not be their name, and that's fine to us. It doesn't matter. But it meant that if someone else got their phone, they may think that the person's getting the messages for a wrong number or something like that. But it also means that it makes it really, really easy to sign up, and it reduces barriers to sign up by only requiring them, their name and their phone number and any kind of required tailoring information, without the need for, say, we have a national health number that every person has in our country, and we don't ask for that kind of information. But what that means is we can't link our data to our national data set. So there's pros and cons, but I think if you're going to gather clinical or personally identifiable information, you then need to be thinking about the infrastructure around the security of that data, and that adds a whole level of complexity, not to just your systems, but how you're actually going to run and maintain these programs. And again, that comes into your needs assessment and your plan for this program.
I think it's also sometimes like for the Cook Islands and the Samoa project, we wanted baseline information. So when people signed up to the program, they did provide a nickname or a name and a mobile number, but also they did provide some information about their tobacco, their smoking, tobacco use, level of addiction. So a bit of information that was really important for follow-up survey. So nothing that would be necessarily sensitive in this context, but also when we follow people up for those particular projects, we did phone people. We had to engage back so that, again, the security of any data is like with any research project, it has to be in a sort of password protected files and so forth. So this is where I feel like some of those skills that you develop or as a researcher managing data is really important for digital health initiatives as well.
Hugely important. And there is another related question, which was just, is there a Privacy Act in place for SMS related health interventions? Which is a very good question, but it's the same kind of thing that it very much depends on your country where you're in, and the health information and privacy rules in that country apply to text messaging as well. So
we have to get ethics approval, not for
just implementing a program,
right.
But we're all subject to the Health Information Privacy Code, which is our regulations in New Zealand. But in your countries there will be health privacy regulations of some sort, and you will still be subject to them regardless of whether it's text messaging or something else. So we can't give you a definite answer for that, but you will have to know what the rules are in your country. There's another really good question here around another quick one, hopefully. A major challenge for someone here around clients who frequently change their numbers or have more than one number and don't update their information at healthcare facilities. And it's a big problem. And it really, again, it's just so interesting. So we used to have this problem all the time when we first started doing these programs. And so we tried to build in lots of ways to make it really easy for people to update their numbers. And then the regulations changed in our country so that people could, when they changed companies or phones or whatever, they could keep the same number. And that little thing, which didn't seem like a big deal to most people in the country, actually just made it hugely easy for us. So it's now the way in New Zealand that most people don't change their number, even if they, lose their phone, lose their SIM card, change companies, whatever. They tend to keep their number so that everyone's still able to get hold of them. But it does vary in different places, and yet we just need to try and make it really easy for people to keep you updated if they change their number, and so they can do it by text message or whatever. You got any other?
Just exactly that, making sure that there's lots of options and it's as easy as possible.
Yeah. I think we are just about out of steam.
You can see the lights changing in here. Now we're on sort of coming up to sort of sunset almost. We've got some really lovely low light coming in.
Yeah, and I think we're starting to get to the end of these questions.
I might just go.
We had a really good response though. Thank you, Swaroop, who asked the question about India earlier, and has given us a bit of a rundown there on what's going on with you. So shall I just quickly go through this?
Yeah,
I think
that
it's
would be
quite
really
interesting. I agree that it is not just feasible to reach everyone and integrate just with digital health interventions, no matter how nicely designed it is. It requires the overarching systems, people and resources to be sync as well and support. Support with a unified intent or common goal. I'm currently part of an NCD continuum of care project in one of the southern Indian cities where we are using IVR systems to reach diabetics and hypertensives to deliver modular health education. And in our assessment of 12 months, it is working pretty well. Great.
Yeah.
But again, it seems local government has no system upfront to adopt and adapt this system from us when essentially we are planning for sustainability. There are very good instances like this where digital health interventions have been implemented with effect in silos, but sustainability remains a key challenge.
I think you've summed it up. That's,
Yeah.
that's the final word.
Yeah, that's
No,
brilliant.
unfortunately, I think that's absolutely right. And are there other questions, Robin, or we?
I think that's most of the one. I think we've kind of covered most of the other things. Someone's asked about accessing the presentations.
Oh,
I
yes.
don't know if we are.
Yeah, I think they are available.
Yeah.
And yeah, Rosie, did you want to make a comment to that last point? Or? So I just wonder whether we finish up these key lessons. And this is really, we came up with these sort of 4 key points that we wanted to make. And it's based on a paper we've just had accepted for Journal of Global Health with the 3 of us and a large group of other colleagues who've done, developed digital health initiatives in other settings. So there's India and Kenya. Tanzania, in the Pacific. Pacific and New Zealand. So, and I think, and this was developed from a meeting that we presented at, this issue of how do you evaluate, how do you determine whether an intervention's been effective. And on that point, I also just want to mention that the WHO monitoring and evaluation toolkit for digital health is a really useful resource to use when you're thinking about that. But one of the things, the 4 things we sort of condensed all our thinking into was designing in partnership with stakeholders is absolutely critical. So there's no end of great ideas that come to people's mind about how you can affect change and make a difference in populations for different problems. But having the key people around the table is not an absolutely assurance of things being scaled up and rolled out, but certainly figuring out who are the key people who have influence, who need to be at the table. And that's both people who'll be receiving and using this intervention and those who'll be paying the bill. And having to be accountable for it. So that's absolutely key. And it seems so obvious, but I think sometimes in the enthusiasm with great ideas, we can kind of run ahead a bit and forget about slowing down and thinking, actually, who do we need to be sitting at that table when this is designed and now ready to be rolled out? Another thing we considered was the focusing on equity right from the beginning, from the concept through to the design and the evaluation. So making sure that those initiatives are really working for the people who could benefit most. So I have to admit, my first introduction with digital health or mHealth was at a conference in Washington where it seemed 90% of the presentations were about precision health. So making healthcare even better for people who are already relatively well served and how they can personalize it and strengthen it. But actually we see some real value for improving equity.
I think, can I just add to that? I think what the biggest potential for mHealth is around reducing health inequalities. And I think there's huge potential because it allows us to reach populations that have been traditionally harder to reach with conventional services. And so I absolutely think the focus on equity and reducing health inequalities is fundamental in the design of these tools. And, if you're going to try and address that, you need to look at what are some of those lower common, the technology that's going to reach the most people. And that's why you'll find that most of our programs have been SMS based and that we are wanting to reach as many people as possible.
I think that's a really good point. I think, again, anything when the word digital comes in, you think about new and exciting and things that are going to be really pushing the envelope a bit in terms of innovation, but actually sometimes simple is really good. Simple you can be, and I'm meaning in terms of access and sustainability. So yeah, so thinking about that right at the very beginning, not as a kind of an afterthought, and thinking about that in terms of how you evaluate, making sure that you are checking in with, you know, all people involved. So the other one I think is really important that we thought was building capacity, capability and ownership. So we really want to make sure that, so with the Cook Islands, I think is a great example of this, is that they were really clear right from the beginning that they didn't want Auckland University to come in and do an mHealth project for them. Because we've done it before, and we they wanted us to work with them to be able to transfer those skills to say, okay, let's now figure out what we need to do in order to run this. Now, how do we do that within this environment? We have to design it with this in mind. Nothing's going to change radically in the Cook Islands health infrastructure or the resourcing. So let's design for the context, who's in our health system, and so forth. So I think that's really important. Capabilities, knowing what and ownership. So again, if you've come in to help an organisation design and develop an initiative, that actually knowing when to step out and actually leaving behind those skills to to make sure it can be run and sustained independently is incredibly important. And that sense of ownership right at the beginning, and that's something that can't be developed in the later stages. It has to be from that very first idea, the very first meeting and discussion before anything's put together. And I think importantly, evaluation can be really, really complicated, and it can be RCTs or it can be something much more pragmatic and simple, depending on what you're wanting it to do. I think evaluation has to be fit for context. So sometimes it's just not practical or feasible or even appropriate to run an RCT to determine effect. We don't need another RCT to determine that M cessation is an effective intervention, because there's lots of them being conducted around the world. What we needed to know was, is this what makes a difference in this setting? Do people want it? Is it acceptable? Is it sustainable? And what we need to do to ensure that can be carried forward. So I think there's a theme of pragmatism here, but also being thoughtful about those elements of design and inclusiveness and designing for context and in users is really important. So any other final points, Robin?
No, I think that's great. Thank you everyone very much for joining us.
Join us, Rosie. Bye.
Thank you.
Thanks everyone.
And thank you for the questions and the engagement.
Yeah, great conversations. Pity we're not all in the same room. We're sorry about that, but we hope you're all safe and well in your countries, and we really appreciate you joining us for this very long session. Bye.
Bye-bye.